we should target reduce the unmet need to about 20% or 25 in the next 10 years. So our activities must be focused on impact as the Adolescent Health Forum. So when we are here, we know we have very key people in the house. We've known Maristops, we've known Plan International, YardNet, our district net advocacy networks, UNIPA. All of you are doing very amazing work. But can we now translate that work into impact so that we all see the impact coming? All right. Briefly, that's it from me, and I hope Stanley is online. We can project. So you're going to just hear from Plan International. Plan International has funded our activity today in terms of booking the hotel. And then we also had support from Naguru Teenage Information and Health Center through the UNFPA program, and have funded us for the past 2 activities, and we hope we shall be funded for the next activities. In case you have some money within your dockets, please, Joel, if you have some millions, just let us know and we shall come and discuss. Yeah. All right, Diana is ready to tell us about Plan International. What should we know? Should we get excited as Adolescent Health Forum and its members or not? Thank you very much, and over to Diana.
Thank you. Good morning, ladies and gentlemen. Do you want to be referred to as gentlemen, as ladies, as young people? Others? No, then that makes you vulnerable. Yet we are not vulnerable. Are we vulnerable? We are moving away from being called young people who are vulnerable to people who are, taking the front spaces to influence policy. So I will not use the others. My name is Diana Tibesigwa. Once again, I work with Plan International as the Influencing and Communications Manager. And I am glad to be part of this conversation this morning with the young people as we try to strategize on how we can amplify and boost our advocacy and influencing for adolescent health. Plan International, some of you know it. Some of you may be just seeing the logo, and some of you may be just saying those people do a lot or less. But we are an international humanitarian organization, and we advance rights of children and young people, especially girls. Of course, there are a number of programs that we do as an organization, and the past years we had programs including health broadly, where we had maternal, child health, we had education, we had livelihood. We have programs in the humanitarian, in the response. And currently, as an organization, I think last week, we launched our new country strategy. And we made a shift in terms of focus as an organization, where we want to strengthen our work with young people in health, especially on sexual reproductive health. And so the next 5 years of our existence in Uganda, we shall mainly, in terms of health, be focusing so much on sexual reproductive health for young people, and adolescents. So that's where the entire programming for health as planned, we will be focusing. And so it was imperative for us to really start looking out for platforms, coalitions, networks that are going to enable us amplify the objective of the organization in terms of improving SRHR for young people, especially girls. And so we reached out to Naguru Teenage Center. We had conversations about Naguru and then the RMNCH CSO platform. We had conversations on how we can be relevant in improving, the work of the ADH platform for better advocacy on SRHR. That's how we came up with this meeting. I know they also had plans of having it, but for it to be faster, to come faster, we needed to put our minds together, and then we came up with this meeting. So in the morning, they took us through a whole line of the program on how it's going to run, and so we are interested in seeing or in having a roadmap that is going to enable us improve our advocacy both at national but also in the regions, which we can call districts or sub-counties. So with us, all of us in this room putting our heads together, I know we'll be in position to put up that document, and it should be in position to facilitate our engagement as a framework to guide our interventions at institutional level, but also at coalition level, to influence and make changes around policies in SRHR, services around SRHR for young people across the country. So, looking forward to all your support and contribution towards this meeting. So, thank you so much.
Right. Thank you, Diana. I think the hand claps are not warm enough. Thank you. All right. A key takeaway there is a focus on young people and health for young people in terms of SRHR. Should we get interested as partner organizations to chip in? And I request Diana, if you get some time to share just a brief about your new strategic plan for the next 5 years and how partners would interest themselves to, you know. All right, good. Okay, we are looking forward. So, like I said, we have a program there for our partner organizations to give us updates. So, I've already received one confirmation from our partner. Please keep the confirmations coming in. Then Plan International will be next in that line. And we are targeting to have our break tea at 11 as the agenda says. If we can even have it earlier than that, the better. So, Olivia? As Olivia is coming, let me make some announcements. One is that you're not seeing a lot of sweets on your tables. Some people came early. The energy levels were down, so they had to really boost their energy levels, but we're going to request the tea to come in a little bit earlier, so that we all benefit from boosting our energy levels. As we are buying time, just to make sure that you have your requests sent in to present about what your organization is doing in terms of adolescent health programming. Just one or two interventions that you know, can be relevant to the platform. Second announcement is that our organizers for today's meeting are environmentally friendly, so you'll not see any bottle of water. The next time you come, we shall not have paper. Yes, because we don't want to cut down trees. We don't want to. We want to save on light, eh? Yeah, the next time we shall save on light. Given that we are projecting, we shall even reduce the number of lights in here. So we have our water behind with glasses. So make sure you do some exercise. The water is cold and warm, so you can choose what you want. I think that is something that we should adopt for the next meetings, given that we have a lot of climate change issues coming up. So as Olivia is coming, we have 3 organizations so far that are going to give us updates. Afrian? Anything from Afrian? We have someone who didn't introduce themselves. Should we give them a chance as Olivia is setting up? Right. My boss. You did. We don't remember. Just say it once again.
Good morning, everyone.
Good morning.
My name is Helen Patricia. I work with Reach a Hand Uganda.
You see, you didn't introduce yourself. All right. What is your step of food, and we shall tell where you come from.
Tea.
Tea.
Tea. African tea, not spiced.
Food.
Yeah, that's my food.
Your step of food. What is that? Chirohora. So from Chirohora, you do take tea. All right. Rahul, any updates for the forum? All right. 4 organizations. So after partner presentations, I'm sure Joshua is also ready to give us an overview of the RMSCH platform. But currently, let's prepare our questions we have a lot of questions around the adolescent health policy. Just triggering your minds to ask things around the policies. I'm biasing instead. All right, let me not bias you, but we have the right people in here regarding policies around adolescent health, and I'm sure Olivia's presentation is going to be centered around that. Hey. As Olivia is setting up, we have very many others who joined us. You're welcome.
Thank you.
In 1 minute. Your name, where you are from, and just a topic.
Okay. Good morning, colleagues. My name is Tukahira Maureen. I'm a feminist leader, and my staple food is matoke and fresh peas.
Okay, Matoka and fresh peas for the villager. We have a villager in the house.
Good morning, everyone. My name is Mwesi. I am a minister, and I prefer mukene with sweet potatoes as my favorite dish. I am from Butaleja.
We wanted to tell where you come from by what you prefer. All right. So we shall have time to understand what minists do. We know what feminists are for. Mwesi, do you want to break down? You advocate for the rights of men. Okay. All right, I think Olivia is ready. Olivia, how much time?
10 minutes.
10. All right, thanks. And over to you.
What is in the slideshow? Good morning once again. Olivia is my name. I am from Ministry of Health, the Adolescent and School Health Division, which is under the Reproductive and Child Health Department. I'm going to share with you some of what we have prepared as a division and as Ministry of Health, the priorities for the next 5 years, which we think shall bring down the disease burden among the adolescents and young people who are aged 10 to 24. Isn't it more? Sorry, there's a technical glitch here. What is it? Why isn't it moving? Save. I've been there working on it and it was okay. Huh? Okay, sorry about that. So as Ministry of Health, a number of situation analysis and studies have been conducted, and we know that even according to the Uganda Demographic and Health Survey, young people are majorly affected by HIV/AIDS, sexual reproductive health issues. We have mental health issues and the burden of nutritional problems. And these are the priority areas of focus in terms of reducing the disease burden and ensuring that the young people remain healthy now and in the future. As a division, we want to see a healthy, empowered and reproductive adolescent population. We are also aligned to the national vision, and our mission is to improve the health and well-being of adolescents 10 to 19, but we also cover the 10 to 24, which is the young people. And our goal is to provide strategic direction to the health sector and partners, those who are working under the health sector, on effective interventions for improved adolescent well-being and development in Uganda. So our program objectives is to increase. We have a strong pillar on information. We want to increase access to appropriate health information and education by adolescents and young people. You will only see adolescents because the primary focus majorly are the young people who are 10 to 19, but we also include the up to 24 in terms of programming. So appropriate health information, this includes all the areas of information beyond sexual reproductive health. To reduce the burden of disease and risk factors among the adolescents. The third objective is to strengthen empowerment and inclusion of adolescents in decision making and programming in adolescent health at all levels of the sector structures. And then the fourth one is to promote the enabling policy, legal and social cultural environment against negative social norms and harmful practices, beliefs and attitudes. So these are our priorities in terms of objectives, and this is what we intend to achieve in the next 5 years. This is how it's designed. We are looking at different levels. At national level, we have the Adolescent and School Health Division as the pivot. And of course, beyond that, we have other structures that go beyond. In terms of policy approvals, we have senior management, we have health policy advisory committees, and then top management where decisions are made. But the coordinating point is the Adolescent and School Health Division. And we know that we have monthly meetings, coordination meetings, under the Adolescent and School Health Technical Working Group that reports to the Maternal and Child Health Technical Working Group. But below central level, we have the district or the subnational level, where we have coordination done under the DHO's office. And there we expect as an assigned person who is usually the ADHO, Maternal and Child Health, and this one oversees activities of adolescent health together with the DHT. And we have a platform there called the District Committee on Adolescent Health, which is expected to mirror what we do at national level. And this is the point that coordinates all the implementing partners and all the other sectors that are contributing towards the health and well-being of the adolescent. And then below that, we have health facilities. You all know that we have regional referral, we have national referral hospitals. Those are the service delivery platforms. We have hospitals, we have health center 4s, we have health center 3s, up to health center 1, which is the VHT, and that is at community level. And at community level, we work through the community, the schools, and the central point is the health facility. So at health center sub-county level, we have a health center 3, and it works and collaborates with the schools and the communities in that space. We have defined, of course, what we expect, the package of what is expected at the different levels. For example, at the spaces, we have parent and caretaker interventions. We have engagement of culture and religious leaders, political, peer advocates, and others. And these make referrals to the health facilities. And then we also have health facilities conducting engagements with these platforms in the community. We have the school, which is also key, the school-based interventions. We have school health clubs, peer advocates, and other school health committees, and all these work in collaboration with the health facility in that catchment. So here we have outreach activities to schools and referrals from schools. So that is the relationship of how this program operates. We expect that issues that come right below from community health center 2, health center 3s, they tickle up to the district committee on adolescent health. And when there are issues that are not resolved at that level, they can be shared. Maybe the CAO writes to the PS of Ministry of Health and then directs to the responsible offices to respond to some of these issues. So we have the strategic activities. For example, under the objective 1, as I had already mentioned, to increase access to appropriate health information and education. Our priority is to build capacity of national and subnational providers to engage and deliver accurate adolescent health information that helps these young people and empowers them to make appropriate decisions. Promote innovation for improved access to adolescent health information. Strengthen behavior change communication for adolescent health, and increase demand and access to safe motherhood and emergency life-saving interventions during pregnancy and childbirth. So this is majorly under objective 1, and those are the priority actions. The second one, under reducing the burden of disease, is to strengthen capacity of service providers to deliver integrated adolescent responsive health services. Strengthen coordination of delivery of these services, and improve access to adolescent preventive, curative, and rehabilitative services, especially those related to the priority issues, GBV, HIV, AIDS, teenage pregnancy, nutrition, and mental health. Strengthen capacity of adolescent health services at family, community, and school levels. Then the third one is about the strengthening the health system to be able to empower and include adolescents in decision making and programming, including service delivery. This has been a major challenge for the health sector in terms of ensuring that we have adolescents as part of services, programming, and others. So here we expect that we shall be able to be supported and supporting the structures to empower adolescents with knowledge and skills in ADH programming, including adolescents in programming, and building capacity of national and subnational governance structures to ensure adolescent participation and inclusion in health service delivery and other interventions. In terms of promoting the enabling legal, policy, and social culture environment against traditional and emerging negative social norms and harmful practices, to address the negative social norms and harmful practices, we plan to see how we improve adolescents' understanding of positive cultural norms and strengthen subnational structures in case management and response to negative outcomes of harmful practices among adolescents. These ones that usually lead to injuries and all that. Support the enabling legal and policy environment for adolescent health, and strengthen multi-sectoral coordination to improve the adolescent program in terms of responding to these issues. The other one is to strengthen evidence-based practice, and here I would like to strengthen research innovation and knowledge management, strengthen routine data collection and use, monitor, and then strengthen monitoring and evaluation of the program. Like I'd already explained, this is majorly a plan that is under Ministry of Health, the priorities. And like I'd mentioned, the Adolescent and School Health Division is at the center, and we have the Adolescent and Health Working Group, for which we expect members to be regular in attendance and contribute to the discussions and decisions. Here we have MDAs expected to be represented, and other stakeholders, including development partners, but of course at different levels. These are structures that happen at different levels. For example, if it's senior management, we have another structure there that meets with the other stakeholders at that level. And subnational level, like I'd mentioned, we have the District Committee on Adolescent Health, which is a committee of the District Planning Committee. This is not a new structure, but rather part of the District Planning Committee. So this is how we shall be measuring whether what we are doing is making impact. For example, would like to know the adolescents who are knowledgeable and demand for their health and rights increased by 50%. New infections among adolescents reduced by 50%. Teenage pregnancy rate reduced to 14%. Mental health, we just have one tracer indicator, reduced from 7%. That is in terms of depression. We know there are many other conditions. Iron deficiency anemia is very high among the adolescent girls, and the UDHS 2016 has put it at 32%. That is the proportion of girls living with some form of anemia, and we want to reduce this by 15%. Mortality among adolescents reduced from 17.2% to 10%, but this is majorly maternal mortality. This excludes the others. This is the commonest and the most pressing form of mortality that is happening among the adolescents. They are contributing 17.2%. Adolescent participation in programming improved, and then adolescent access to SGBV vac services increased by 25%, and negative sociocultural norms and harmful practices among adolescents reduced. Primary health care facilities, schools, and community, with providers trained in adolescent responsive service delivery. Here the minimum is at least 2 providers, and then 5 for hospitals. Hospitals with functional adolescent health services as defined by the standards. This is a continuation of the indicators. We shall be looking at health facilities that have adolescent responsive IEC materials, guidelines, and standards, updated guidelines for M and electronic health for callers, disaggregated by age, proportion of districts with parent and peer groups for adolescent health, and proportion of districts with mobilization and sensitization sessions on adolescent health, including mass media, Proportion of teenage mothers with accurate knowledge of safe motherhood package. So we look at the proportion of districts sensitizing communities on the safe motherhood package. This is another big area of proportion of adolescents who were screened, vaccinated, adolescents who received treatment. So this one is a big one, but there are many issues in there. Proportion of adolescents who had their first ANC visit in the first trimester. This refers to increasing ANC attendance among the pregnant adolescents. We know that we want them not to get pregnant, but once they are pregnant, they should survive the pregnancy. And we encourage them to attend ANC to help them survive and also increase contacts with health workers and get information on prevention of pregnancy. They should be attending, of course, at least 8 visits. And we want to also track proportion of health facilities that provide integrated SRH GBV services for adolescent health. We also shall be looking at proportion of facilities with community health workers trained in adolescent service provision. And then districts with the ADH initiatives that integrate livelihood support is also another area. We have the number of CSOs and CBOs with MOUs for adolescent health with the districts, and proportion of districts with feedback mechanisms in place at health facility and community level, and proportion of trained adolescents that actively participate in community ADH service delivery per district. Here we are looking at inclusion of young people in the VHT system. And then proportion of districts with coordination structures for partners and private sector in ADH programming. So this proportion of health facilities that provide opportunities for adolescents participation as either peer educators or peer mobilizers or service providers. We need to have an ADH research agenda as one of our areas, and then proportion of facilities with record officers oriented in ADH data collection, analysis, and use for programming, and then proportion of districts with functional DICAs, district committees on adolescent health. So these are some of the priority indicators, and I urge you, as in whatever we are doing, we should be contributing to this to ensure that what we are doing is going to improve the indicators as we have stated. Thank you very much for listening.
Thank you, Olivia. I think our questions have already been answered, so we can go to the next agenda item. You have questions? Olivia, people have questions for you. You can rest the laptop and then get a pen and a paper. For me, I thought all questions were answered from the presentation. Huh? Okay, we're going to take a round of 5 and then see if we have any. We have 1, 2. Any other? I'll be 3, 4. One more? Okay, let's first start with those ones.
Yes, thank you so much, Olivia, for this wonderful strategy. It's really a good direction. However, I would love to understand how, or to be guided, how we harmonize with Ministry of Gender for the out of school. Because it's a good strategy, which is very good, and it targets those even in school, but out of school, we are missing the other part. I don't know how the organizers missed Ministry of Gender will also be here. It would also harmonize very well what Ministry of Gender is doing in their strategy, and see how we can tap into that strategy with the out of school youth and adolescents, because there are those who are out of school now, and how do they tap into these other programs, and so that we harmonize, and also we track the indicators, because we have indicators, very good indicators in regard to adolescent health, and now we want to see how we can harmonize together. Thank you.
Thank you, Bernard. I was in a taxi one time and I overheard people say Ministry of Gender is having some SRHR interventions around service delivery they are implementing, and I'm like, Ministry of Gender and SRHR service delivery? But I wanted to believe that I was in a taxi, so that was just taxi vibe.
Thank you so much, Olivia, for the presentation. However, I think mine comes in after his of the strategy looks at people in school, leaving out young ones who are out of school. Yet the information under objective 1, we are seeing you having a strategy of sharing the information of SRH to these young people. And this information is always in English, leaving out the young ones out of school without information, hence falling forth to the effects that we are seeing. Then the other inquiry that I have from my side is that as we are looking at these hospitals, are we also looking at equipping the youth friendly corners with all the necessities that are needed, from the health worker up to the information you're talking about, or we are still leaving out the health corners and young people are still also facing the challenge of not, getting services with older people, then feeling offended that they are meeting their parents in the same place. So I really wish to understand when it comes to the health facilities that you're looking at. Thank you.
Hello. Thank you so much, Madam Chichoncho. Mine is on the indicators. You shared the indicators on how you want them to be reduced. I don't know whether you're hearing. You're listening? Okay. Well, I wanted her to look at me. I'm here. Okay, just hearing. All right. Yeah, the indicators are well stipulated, but you're showing us how they're going to be reduced, but I don't see the time. So which time are you looking at? Which years are you looking at? Then the other is a concern. The DHSI2 shows indicators on first A and C and the number of deliveries for teenagers, but it's not well disaggregated. It only shows 10 to 19 years. So if I am a programmer and I want to know how many girls are getting pregnant between the age of 10 to 15, I wouldn't have that information. So I don't know who is responsible at refining that, because I think it's very important. Number of deliveries and ANC, at least for those two, I know they only show 10 to 19. I think the past years of 2018 and 17, the data was more refined, but this one is really not clear. Thank you.
All right. Thank you, Charles. Olivia, I have two. One, you talked about IEC materials and how ministry is focusing to have IEC materials in health facilities. According to our previous study of how young people are taking up youth-friendly services, we understood that those health facilities don't have IEC materials. So we want to know who is responsible for printing and disseminating these IEC materials in the health facilities. Number two is, okay, we have some more two hands coming up. Number two is the new Chapin plan. We have adolescent health has about less than 2% earmarked from the entire sharpen plan budgets. And I just want to know what is the role of the division to ensure that at least adolescent health programs get some funding. At least if we're looking at the FP 2030 commitments, we have about 10% of the entire SRHR programs earmarked for adolescent health. So how do we look at ourselves looking at achieving that figure in the near future? Okay, I have 2 hands.
Arafat, are the people online?
The people online. We said we are going to take 5 questions first, then we come back. So let me take the 5th, and then we take the other plus the people online. The 5th one from behind here.
Thank you, Olivia, for the presentation. I may have missed something, but Arafat did mention issues around the IEC materials. But what was coming into my mind is that the other platforms other than the print, like as a ministry, what have we thought about in terms of application of the digital platforms and other elements to enhance that scale up so that we're able to reach both in and school? I know that colleagues have been talking about the out of school, the in school. What is the design? What innovative approaches are we looking at to ensure that, especially with the lockdown, or some of those platforms that can enable us to reach the young people?
All right, we're going to give Olivia a chance to respond to those ones, then we come back. Josh, I heard something around IEC materials. No, another one. You want to make it 6? Right, I request humbly 5. Then we come back to the next round. Thank you.
Okay, thank you very much for your comments. I want to begin by responding to Bernard about the out of school, and I wanted to refer you to this diagram. I mentioned that as health, we work through our health facilities, but we have the linkages to the other players. For example, here we have the adolescent-friendly health spaces at community, where we expect the out of school to go to, and those are majorly by Ministry of Gender. Ministry of Gender has youth groups, and they have different kinds of spaces for these young people. And the role of the facility is to have the linkages. We have an understanding where of course, where people are very organized, is that you have the linkages happening. If there are spaces in the community, you have the health facility working with those spaces. For example, in terms of taking services to those spaces, information, and we have referrals happening from those spaces to the health facility at different levels. Can be hospital, it can be health center 3, depending on the issues. The same with the school. You can see there's the arrows here. We have health workers moving to schools and supporting the school health program through the school health committees in terms of responding to the different issues that affect the young people's health. And we have referrals from the what? From the schools. So that is how we work for the in-school and out of school. And that is at that level. When it comes to the upper levels, the central level, our platforms should be bringing us together and planning, having joint plans and joint supervision, joint programming. We know that Ministry of Gender has already come up with the child policy and the youth policy, and that is where the guidance is coming from. And for us, we have picked out what the health sector has been given to do, and this is what informs the plan that we have developed. The other question was in terms of time. I mentioned at the beginning that this is a 5-year plan. This is 2020 to 2025. So our indicators should be reducing within the next 5 years. We shall do the measurements for impact at the end of 5 years. The other one was the disaggregation of data. Yes, this is for ANC first visit is not well disaggregated in DHIS2, but this data is available in the primary data tools, in the registers. Age is picked. So when you want to do further analysis, you can visit the registers in the health facilities, and you'll be able to tell how many of these adolescents are attending the first visit in the first trimester. Then the issue of IEC materials, when I mentioned the IEC is beyond print, and we have also considered the digital through innovations, and we are cognizant of the electronic and mobile health, and it's one of the platforms that we know is popular for the young people. However, there are still challenges in terms of making that possible. But we urge the partners that we are working with to have that gap, also to look at that gap and work with us to ensure that we have standardized information and it is reaching the right people, whether in school or out of school. Then the other one, and the role of course, Ministry of Health, their role is to do the standardization and ensure that these services, the information and health services reach the right population, and ensure that it is up to date and it reaches everyone that needs it. I hope I've covered all the comments, the questions. Thank you.
All right, thank you, Olivia. I request we keep our questions short because we have a mouthful from the online. We have 1, 2, 3, 4. The fifth one from here before we take the mic. All right, then we shall go online. Let's start with then I come in that mic.
Thank you, Olivia. Again, my name is Helen. Thanks for laboring to take us through that. I just have 2 questions. One, how can we integrate this program model into other government running models? That could be maybe pillar 4 and 5 of the PDM, and other structures that are running in government which already have budgets allocated to them. How do we integrate this model into them? Then secondly, what are your expectations after presentation to the parties that are here? Is it to pick and integrate in what we're doing? Are there areas of collaborations that we can already start to think around after your presentation? Thank you.
Raymond?
Thank you very much, and thank you, Olivia. I don't have a question. I have a recommendation which emanates from the previous consultation with the ministry and stakeholders in relation to the model and in putting in the indicators. In the previous engagement we had, there was a commissioner from prisons who gave up, who came up to request that there is a big gap in the prison in relation to the young people accessing services therein, and there was a request that we could integrate in our model, in the program model, to also reach the young people in the prisons, and also developing an indicator in relation to that. So I don't know at what level we'd have such ideas from the stakeholders reflected. For us who work with the players in this, we thought this is the key, and those are vulnerable young people who need services, especially in the prison service, who are in there. So how do we reach those vulnerable young people with services? And also, how can you have this, would be proposed to have incorporated in the model, to get indicators, to reach them, to get partners, support prisons, and have these incorporated in the program. Thank you.
Thank you. Yes, Carol?
Thank you very much, our presenter, Olivia. I had 2 questions, but I think one has been addressed about the the youth-friendly corners for the adolescents. And then the other one, I just wanted a note of inquiry about the ANC visits. We of course they changed from 4 to 8 visits, but I wanted to know if in any of your datas, maybe in the HIS2 or wherever we could, because we wanted to know if you have anywhere that shows that all these 8 visits have really been effective out there in other regions, because in Eastern Uganda, where HEPS Uganda has been working, and in other regions like Imbara, Gulu, really the facilities where we work, they tell us these people only stop at either the 3rd or the 4th. No one can come for the 5th and the 6th and the 7th up to the 8th visit. So maybe if you have any data that shows that all the 8 visits have been effective and how they have managed to have those work. Thank you.
All right. Thank you, Carol. We'll go to Joshua, and then Bridget is online with one question.
Yes, Joshua is my name again. So mine, you've talked about the VHT system, having the young people integrated into the VHT system. I request that you share with us some more. If you have started on this, how is it being done? I think some of us who are also into supporting service delivery would like to learn from you what it is exactly that MOH is doing with integrating young people into the VHT system.
Bridget?
That was a long wait. Thank you so much, Olivia. I have just one question alongside what everyone is asking. We appreciate that so many players in making sure adolescents receive health services. I just wanted to know, based on your presentation, how are we going to capture what everyone else, what all of our partners are doing to really to service into our indicators? Because we know, apart from the streamlining health services at the facility, there's a lot more that is happening that other players are doing in terms of information, in terms of taking services into the communities. How is this all going to be captured so we see what we want to see in terms of the indicators? So in terms of monitoring, in terms of evaluation, but also in terms of accessing this data. Thank you so much.
Thank you, Bridget. I think we can hand over to Olivia. We don't have any other questions online. If we do, we shall take them. But
so I'll begin by with the comment from the recommendation from Raymond. Raymond, that is very good, but I also wanted to request that if any of you has some funding, could do some situation analysis in the prisons, and then that can inform the kind of interventions that we can take to the prisons, because you will need to know what kind of issues are affecting them, who are their service providers, how do they sustain those services, for example, and what kind of help would they need. So it would be important, this is what I'm recommending, that kind of situation analysis is conducted, and then it can inform the kind of support we can give the prisons. The other one is, she asked what my expectation is at the end of this presentation. I had mentioned that I expect that we all align to the priorities and take note of the indicators and ensure that whatever we are doing speaks to the indicators that we expect to achieve at the end of 5 years. In whatever intervention you do, try to make sure that you probably refer to the DHIS data. If you're working with Ministry of Health, how are you increasing access to post-abortion care, for example? because we know at the end of the day that is going to help in reduction on mortality for that age group. In whatever you're doing, look at the indicators. How are you contributing to reduction in the iron deficiency anemia among the adolescents? So we need to have that in our minds in terms of in whatever we are doing. Of course, we have the empowerment bit. I know most of you do empowerment, but at the end of the day, we want to see an increased number of young people who are able to consult the health workers on preventive methods, on prevention of these diseases. We want to see less and less of young people coming to the facilities when they are ill. So that is something for you to think about. Then in terms of performance of the 8 visits, ANC visits, these are not yet doing very well, but this is where we still have a role to play to disseminate this information and increase awareness among both the older people and the young people, because we know the older people will also influence the young people once they are in this situation. So I cannot give the data as of now, but I know they are not doing very well. And in terms of ANC, while the older women performing maybe at 99% for at least one visit, the young people are doing much less. They are not doing well, and that is where we need to focus. How do we capture what we are doing? So this one, because I think that is why we are organizing ourselves. We need to regularly attend the platforms, coordination platforms, and share what we are doing. And at the end of the day, we need to share reports. At least partners should be sharing annual reports aligned to the indicators that we have shared. And this is going to help us to capture what we have done, and we shall be able to evaluate ourselves at the end of 5 years and know what has worked and what has not been working. And of course, we need to conduct surveys to capture what we are doing and how we are performing. So I think that is it. Thank you very much.
Thank you. I realize it's already 11. We have some questions online, but I'm going to request that you answer them like in 1 minute. One is about the dikers. Angela says she's not seeing how the dikers and their structure align into the structure that you have presented. There is no mechanism. So maybe you can help her understand. I hope I've picked her question right.
So the DICA is a committee at the district level, and it's a subcommittee of the district planning committee. And that is how it's supposed to bring the different players at district level who are contributing towards adolescent health, beyond health workers, beyond all the CBOs, including all the other commercial officers. You have the district office, health, DEOs, and all that. And that is the structure at district level. And I mentioned that when there are issues that cannot be solved at that level, the chair, who is the COW, writes to the PS of Ministry of Health with the specific issues, and the PS will direct to the responsible department to respond to those issues. And that will be majorly, of course, the adolescent division will respond accordingly. So that is how we expect to work. But we expect most of the issues at that level to be managed by the DHO's office through that platform, and ensure that services are coordinated and are of quality, and young people are reaching the right population. Thank you.
All right. Thank you, Angela. I have a request. Sorry, Olivia. I have a request that we make Olivia a permanent member of the ADH Forum, non-replaceable, because we have a lot of issues and a lot of questions to ask. I don't know if all our questions have been answered, but given the time factor, I would request that we let Olivia take her seat, and then we dive into the next agenda item. But before that, I want to ask Joshua and our partners who are coming in next, given that it's 11 o'clock already, could we have a quick tea and then come back and, yeah. Thank you, Raymond. Uh, okay, she has accepted to have a one-on-one in case you have any other question. So members, including Joshua and the people who are going to present, is it okay we have like a very quick tea? It could also act as a house break or a washroom break, and then we come back and have another marathon until lunch. That's workable? All right, thank you. We didn't pray in the morning, so our tea is not blessed. Anyone, any pastor here? Reverend Nathan had promised to come, but he didn't make it. He would have prayed for our tea. We have a volunteer here. Thank you. You can pray for the lunch together.
Let's pray. For that is set before us, Lord, we thank you. Thank you for everything that you've given to us. Bless it, bless the hands that have prepared it, and let it do good in our lives, all for the glory of your name. In Jesus' name I prayed.
All right, thank you. A very quick one. So let's take our tea very quickly, and then we come back. Our members online, we request that you also take a break. Don't go offline, just take a break. Have a cup of tea, and then we convene in the next 10 minutes. Thank you. Mwesi, you came from all the way from Butaleja. You should be the first online. Thank you. And then others will also follow. All right. Members, I request we reconvene. As we are waiting for the few members at the back to finish up. So I'm going to read out how the presentations will flow. I have so far 6 organizations, 1 online, 5 are going to present physical. I'm just hoping that you don't have like a presentation, you just stand and give us a brief 1 or 2 lines about what you're doing within the adolescent health arena. We'll have the Heroes program will come first, and then I want to give the second opportunity to our partners, Plan International, and then NYHN will come in the 3rd place. Reach a hand number 4, and Naguru Teenage Information and Health Center will come 5. Acts 101 will come 6th. Yeah. So in that order, I'll be reminding you the order. In case we get any other 7th, 8th, 9th, and 10th presenters, we'll be also letting you know. So let me welcome the representative from the Heroes program. You have about 5 minutes or less, so if you can work within 3 minutes, it will be okay. Any other additions will be 1. Yeah, you're welcome here. You want to present? So Plan International will come number 2, so I request you prepare. In case you have a presentation, you can also share it with us so that our online participants also benefit. And then after Plan, Vicky, you should be ready. Maybe you can just present from here. Projector. Slow. It's slow. You have a slideshow. Could we start with the Right. Stanley, is it okay if you're ready? You can come as we are working out this one. Yeah. Okay. Stanley, maybe you can complete your tea. Sorry about that. Edwin is requesting if you have a presentation, please share it on his email. Edwin, we request you write your email somewhere so that we share the presentations before we present. You have a presentation or? Okay.
We're sorry for the technological issues, but I'll try to be as brief as possible. I introduced myself earlier. I'm Mike Myonga, and I'm a program manager for Heroes. So I just came up with a few slides, share this with you about the Heroes program. These are some of the young people. Maybe before I make the presentation, I would like to say that the contribution or our program in a way is aligned to what Olivia has shared with us. So I will just give a little bit of background. I'll talk about the program objectives. I'll talk about the coverage. I'll also talk about our model a little and a few milestones. The Heroes program is basically looking at addressing the severe forms of gender inequalities, which in a way are affecting health outcomes. And this is a program that is being implemented in 9 high burden districts, which I'm going to be talking about. And we designed to empower young girls, boys, and women to make informed decisions as far as SRHR is concerned. We're implementing this program in a consortium form on the basis of comparative advantage, and we do promote synergies. As an approach, we look at gender transformation. We're looking at health system strengthening. We're also looking at the human life development cycle, and then also meaningful involvement of young people. In terms of the partnerships, AMREF is the lead partner in this. We have CODED, which does result-based financing, and we have International Center of Research on Women, and then also MIFUMI. Those are the consortium partners. In coverage, as mentioned earlier, we're in 9 districts. We have 3 clusters. We're in Bugiri, Iganga, Mayuge, and Amaingo in the East Central region. In the Eastern cluster, we have Budaka, Obuko, Kwen, Mbale in the Eastern region. Then in the Central region, we have Kalangala. There are special characteristics around these districts in terms of high burden in as far as teenage pregnancy is concerned and the SGBV burden. Now, in terms of the target population, both the primary and secondary target, the primary is mainly the 10 to 24 years, both in and out of school, both boys and girls, and women in the reproductive age group, 15 to 49 years. But we also know that this is looking at the ecological model that we use in delivering these SRH interventions. We're also looking at the social influencers, the old men, women, the media personnel, the politicians, among other things. Then we also have the gatekeepers, religious leaders, and this is really consistent with the framework that the colleagues from the Ministry of Health presented. We look also, we also working with the health workers, the VHTs, and all these in terms of addressing a number of challenges within the community. In terms of the model, we are operating at facility level and health facility level and also community level, where in this, amongst the beneficiaries, we're supporting them with, we have health entrepreneurs, we have VHTs who have been trained, and all these make contribute, peer educators, and all those community leaders who make a contribution in creating an enabling environment for the beneficiaries who were highlighted earlier. Now, we're looking at we're using a multi-sectoral approach where we have education department as part of this. We're working in schools. We also look at, we're also supporting health facilities. I'll be mentioning, I think, some of these we're working in 54 health facilities. I'm trying to move fast to enable. We have 54 health facilities, 90 schools in the 9 districts that we're operating in. And as a program, we're looking at empowering young people in these 9 districts to be able to fully enjoy their sexual reproductive health rights and enjoy and live in a community free of GBV, free from SGBV. So we have 4 pathways One is on information. We are looking at provision of information, which leads to greater freedom of choice for young people about their sexuality. We're also looking at better public-private health care, mainly looking at supporting the health system to deliver some of the services, including family planning, childbirth, and then post-abortion care. We're also looking at another path or objective is that we're looking at having more respect for sexual reproductive health rights, where we are making a contribution in terms of transformation of supporting the positive norms. And the other aspect we're looking at is that we're looking at enabling, having an enabling environment for young girls, women, to ensure there is elimination of violence against women by looking at the SGBV response system. What has happened so far? In terms of, I've just highlighted a few of these. We are rolling out a number of curricula, including Journeys Plus, Program Y, Synovuyo, and family health groups. And through this, we have reached about 240 beneficiaries using these different curricula. We also work at supporting the health system, the governance structures in terms of the building blocks, and we strengthen the district health unit the district health management teams in 9 districts where we're working through trainings and supporting them in transformational leadership and governance. We also reactivated, I think Olivia talked about the district committees on adolescent health. Some of them have not been very active, but as part of improvement of the governance, we've also reactivated them, working with the Ministry of Health colleagues. We also work and support, or we've supported health unit management committees in the facilities where we're working, where we've gone through their roles and responsibilities, in a way strengthening their leadership in governance, so that they really link the health facility to the communities, and we are beginning to get results. One of the areas in terms of the health system building blocks, we look at the health workers, and we've also supported the training of the health workers in the SRH program packages. We are also rolling out result-based financing in health facilities, and deliberately we're looking at facilities where the government RBF program is not operating, and so far we're supporting 18 facilities. And for the SGBV program, we have advice centers which serve as a hub, and we have 9, 1 in each of these districts to support the SGBV programming. We've also supported the reactivating of SGBV steering committees, and this also is in 9 districts. And as part of this, we also have a database that really documents some of the key outputs coming out through this. We've participated in some of the events, including the 16 days of gender activism, and the Day of African Child, amongst other things, but really promoting some of the programs which expose the young people. We also look at promoting laws and guidelines in terms of sensitizing the community, so we reach out to them, simplifying some of those laws which can help in terms of the SGBV response system. In schools, I did mention that we're in 90 schools, and in 90 schools, we've the school management committees have been oriented so that it really create an enabling environment within the school settings. As part of this response, we're supporting 18 CBOs who have been oriented in the SRHR programming, and these are 2 per district, to ensure really continuity of our services or activities even at the end of the program. What are we observing? We saw is in terms of key lessons, we realize that the RBF programming is really contributing to the improvement in terms of the health outcomes, in terms of deliveries, ANC attendance, amongst other things. Then this is the critical engagement of leaders, especially in management for the schools, in terms of governance, is really giving us some level of milestones. The multi-sector approach is also critical, and for purposes of the ownership of the program. I think those are the highlights, and these are some of the young people whom we've been working with. Thank you very much.
Thank you, Michael. We shall reserve the questions for a later date when we have a bit some time. So I request if you have a presentation to make, you make it brief, and then you can also share with our IT person. The email is here. I can read it again, Chiveru at ESO or esolutions.com. Chiveru at esolutions.com. Please share your presentations so that our online participants can benefit. So let me welcome Stanley as Stanley is coming to set up. You can note your questions. When you get time, we shall come and present. We shall come and ask. As Stanley is presenting Victoria, we should get ready. And then after Victoria, we shall have Helen from Reach a Hand.
Yeah, so hope you had a nice break. Sorry for the water. As we move towards the climate change, I think it was very important for us to, observe some of the smart ways of living. I think later on we shall have Raymond tell us more about this. So I'll take you through this presentation. It's just maybe on a brief. I know it's a long one, but we shall have a brief on how plan is going to mirror SRHR. And again, Diana did mention that plan narrowed their programs into two. We have the LEARN, which is purely early education, and then early childhood education, and then DECIDE, which is pure SRHR. So I don't want to take you through this process of how we came up with this country strategy, but maybe of interest is the statistics that again has been shared and over again. I know you've also seen this in different platforms, UBOS, Uganda demographic health surveys. But what's interesting is that out of this, the girl child is still the most affected. most marginalized, and also in terms of services, they are the most people that do not access the different services. Again, due to different issues, we all know social norms and perhaps even information. So the strategy looks at this situation from the perspective of the girl child. Again, the reason is people ask us, why are you only dealing with the girls? Yeah? Why not the boys? Yet they're the perpetrators. Okay? If you talk about teenage pregnancy, it's not the girl can't get pregnant alone, right? Okay, maybe unless they go for surrogates, you know. But at the end of the day, there's a perpetrator, there's someone, there's a driver. So, but why we are investing in the girls simply because they're the most marginalized, they're the most disempowered, they're the most disadvantaged. So you look at our issues around the situation. Girls are at risk and affected by child and forced marriages. In your communities, you know that. And also we have high incidence of SGBV. Again, that affects the girl most. We have skills mismatch, okay? And youth are unemployed. Also, if you do a critical analysis, you see that the girl child is actually most affected. There's high number of out of school dropout, okay? There's high burden of inadequate parenting and practices. We have been having serious debates on the adolescent health platform whether parents now need to be, targeted more than yesterday, because they're the primary bearers of this child. But we are saying they don't have information. We have seen early marriages on children. Now I've said that. We have seen early pregnancies, STDs, HIV prevalence. If you read the reports, you see that in this COVID lockdown, post-COVID, already young people are presenting with HIV/AIDS, and mostly around girls again. So high fertility rates. Where I come from, we are told that we are the most fertile, next to, I think, Averole or somewhere, at 6.2%, So on average, in my district, one woman can have at least 6 children, okay? So all those have a burden to the girl child, and of course, the economics of the families. But just to give you a glance of what our CSP will look like, in the next 5 years, FY 23-27, we want to see children and youth, especially the girls, develop to their full potential in communities that promote their rights and gender equality. So the aspect of right and equality are very key. Rights to services, rights to education, basically the universal context of human rights. So I've talked about the learn, which is our dimension of change, and then also decide. So in the education area, I want to enable quality learning experiences for children from early childhood to working age, while building their skills for life and work for in and out of school settings. So as I said earlier, that our education programming is going to dwell more about on early childhood, but also skilling the young people. And skilling, maybe even, again, the debate around the PDM model, how are young people involved? Are they benefiting? No, because it has a link to how they access services. Of course, when you have no money, you can't afford ESP. I mean, how they call it? ECP, rather. You can't afford contraceptives, like condoms, Then also we have, now they decide where SRHR actually is more entrenched. So we want to promote the protection of girls from child early and forced marriages and unplanned and undesired or forced pregnancies. and sexual violence, while enabling access and use of adolescent sexual and reproductive health and SRGBV services. So again, that's our broad thinking of how the design project is going to support, but largely we are going to look at those areas trying to address issues of forced marriages, which is purely a cultural, social norm issue, issues of forced marriages and unwanted pregnancies. You know, when you get pregnant, was it out of rape or was it out of consent, but you want it as a girl? So all those questions will be answered in our subsequent discussions, perhaps when you're implementing. So we have a cross-cutting theme, which is the lead. So lead is more of empowering and building the girls' agency, developing children and young people's active citizenship in terms of supporting their collective action and building effective partnerships for powering the movement. Again, this is why this meeting perhaps were also called and were invited to take part, because it's going to address more of the influencing and advocacy, but also building your capacities as young people to challenge, but also to put duty bearers, hold them accountable, and above all, work in partnership. That's our call, that we can't deliver this at H alone, so we want to leverage on your strengths and opportunities that you have, your capacities, but also the energies that you come with as young people. How are we going to deliver this in terms of methodology? We have, for education, we are going to do what they call community-led action for children. We shall be having spaces for young people, for children at communities. We call it CLAC, learning through play, okay? I know growing up you enjoyed playing a lot, so along the way, you know, how does it shape your emotions, your understanding, your, social life? Positive parenting, okay? Participatory school governance, where young people can hold even the school governing body accountable, savings, again, from the skilling perspective, and then climate change education. We want to make sure that this takes root right from primary. We have what they call the disaster risk clubs in schools, We were told that most of us are shaped between 0 to 8 years. So you are who you are because of, So if you learn to do certain things at some other age, I think you can continue doing it. So we want to see how climate change can be rightly placed within the childhood days. And then at the side, we are going to use Champions of Change, which is a model that we use to discuss gender issues and dialogue gender. And then also we have peer education, something that again Olivia alluded to, community and couple dialogues, parenting. How do we involve the community in all of this? Again, this will speak to the standards, the service standards. How are communities involved in day-to-day, role in shaping the young people? We shall use the Young Student Scorecard, which is a very good tool we use for accountability, where we hold duty bearers accountable right from the community to the district and even national level. A very interesting package. I don't know if you have any district advocacy networks in the house. We shall be engaging religious and cultural institutions who are leaders, who shape a lot of norms in the communities. They should be able to speak to the communities about what happens at community level. Is actually child marriages something that they want to carry on with? Why is it a taboo talk about sex, for example? How are they supporting the parents to understand sexuality and begin talking to young people about sexuality? Then, of course, the most controversial and deserving, Olivia, comprehensive sexuality education. Again, in the line of thinking, we are talking about family planning, talking about post-abortion care, but how do we give this information comprehensively and I want to have a disclaimer there, it's not about gay rights or lesbian rights, neither. It's about how do you give information comprehensively. If you're talking about MHM, yeah, mental health management or health, how do you make it comprehensive so that the young person understands how days are arrived at, how they dispose the hygiene issues, what are the social norms associated to those, the myths and misconceptions. How does it disempower the girl child, in terms of their attitude, their self-confidence, all of that will be dealt with in that place. So at our influencing agenda will be mainly around ending better early child care, like for education, safe and more gender responsive schools, okay, social protection for poor children and youth and their families. We shall look at the legal frameworks and education policies that protect and promote the girls' rights to make informed choices about their sexual and reproductive health, support them to access quality SRH services and information, and to be protected from the early pregnancy and sexual gender-based violence. So these are issues of where we build the nexus or the integration between the decide and learn. Again, we have noticed that, or we have heard that when girls are in school, but again, during COVID time, you notice that when the girls are out of school, the men were at what? The boys, not the men actually. The boys were at rampage, okay? The girls got pregnant like no other day. So we are saying that when girls are at school, they're more safe. So how do we draw that? How do we integrate SRHR within the school setting? And then how do we ensure that we're able to inform or empower the schools to pass this information? I know the education guys will come and tell you that, in schools we have this boundary. We are using the sexuality education framework. We have the PSA, so you can't talk about, A, B, C, and D. So, but that's okay. But they're saying when the kids come out of school, we need to begin empowering them with information. So under the decide, I don't know, maybe the activities we shall do, want to see children and adolescent, particularly adolescent girls, enjoy quality SRHR services, information, education, and better protection from early pregnancy and sexual gender-based violence. I've said that. Activities will be mainly around community and family couple dialogues on SRHR, ending teenage pregnancies, sexual violence and positive masculinities, strengthening adolescent sexual reproductive health rights services, including outreaches, referral, and post-abortion care services, the champions of change, involving young people in terms of participation in monitoring and evaluation. Yeah, I think I mentioned this earlier before. So influencing priorities, again, I've said that. So our indicators under the decide, we want to see percentage of young people aged 13-24 who feel are able to make informed decisions about their sexual and reproductive health rights, and then parents and caregivers and family members who have positive attitude towards young people, okay, on their sexual and reproductive health rights. And then the other is the percentage of children and young people who have used an SRH service in the past 12 months. And then the number and quality of young people, young people's organizations own and take joint actions on issues of SRH. So, I said earlier, we want to see you as a network, you as a young people's organization come together to work to ensure that we put an end to this vice. And that will require a lot of efforts in terms of partnership, but also ensuring that we work together like this to put our duty bearers on task to perhaps explain some of those indicators why they're not changing, but also how do we encourage us to do better interventions that can reach out to the young person in terms of information. SRHR is about information. The more people reach, the better. So, yeah, I think that's what I had. Maybe just the last one on climate resilience. We want to support risk assessments and planning at schools, and mainly the governance areas. Raymond, take note of this. Promote family planning, use of modern contraceptives and birth spacing to contribute to lower population growth, and then build children's and youth families' resilience through saving, and having cash. We say the cash is very important for a young person. If you have to access services, linking young people to green innovations with market-oriented technical and business skills development. So if you go to our communities, you'll be seeing young people making reusable pads. They're participating in these climate change interventions, nurseries. If you go to the ghetto world, Lydian will tell you that the ghetto youth are also doing a lot of green innovations. So that is how we are going to work together. So at the end of it all, this is our theory of change. We want to see children, youth, especially girls, develop to their full potential in communities that promote their rights and gender. And mainly we shall see those that are vulnerable and excluded children in Uganda that acquire an education and skill they need to succeed and make a decent living, then enjoy quality SRHR services, information and education, and better protection from early pregnancy and SGB. So those are our targets. And then how we are going to do it is the whole, things I've talked about: social norm change, skilling, policy advocacy, and information. But above all, working in partnership. We want to develop young people's active citizenship. Again, we want to engage a lot of couples. We want to develop a lot of parenting skills. We want to use SOCOA card as part of our demand creation, but also accountability. We want to do a lot of support, agencies, and build resilience to climate change. So that's what I have for you today. And thank you so much for listening.
Thank you, Stanley. I was just looking at our agenda and we've done ourselves a disservice. But thank you for the presentations. I was requesting kindly, we first pause the presentations a bit. We give about 20 minutes to Joshua. Joshua, would that be enough? 20? For the overview, and then you dive into the development of the leadership structure. And then in the next 20 still, we give time to Diana to take us through the advocacy roadmap until the top of the hour at lunchtime. If we save some 30 minutes, we can dive back into the presentations and then the next steps. Okay, thank you.
Good morning again. It's still, it's afternoon. Okay, yeah. Please forgive us. We started very early. We started a bit late, so we are a bit behind schedule. So we have requested that we revise our agenda a little bit, and maybe we shall work backwards. Is that fine with us? Because there's an item that we need to kick off. We need to give enough time. And I know that sometimes after people have had lunch, they get temptations of dozing and misbehaving. So I want to make sure that by lunchtime, we at least have our some of the key outputs ticked. So I've been asked to talk about the RMNCH CSO platform. How many of us are hearing about this platform for the first time? Okay, there's one person, 2, 3, 4. Mercy, there's one on your table. You start from there. Because I could also, if we all know about the platform, then I don't have to talk about certain things. You're going to handle her. Very good. Who is going to handle Doreen on the other table? Who knows about the platform? We have 2 people on this table. Dr. Ben. Okay, let me run through quickly. Okay, so ladies and gentlemen, the RMNCH RMNCAH plus N platform, it focuses on strengthening the coordination of its members who are civil society organizations. Okay? And mainly, it's focused on strengthening their capacity and coordination on implementation and monitoring of RMNCH service delivery in Uganda. And specifically now, we also now included GFF implementation. GFF is the Global Financing Facility. Okay? We know that Uganda is getting a lot of money from the GFF, and so as civil society, we are monitoring how the government is utilizing these funds. So this is part of our mandate as the platform, as the main platform. I'll then come back to the ADH Forum. So the other focus of the RMNCAH plus N platform is to strengthen civil societies to engage at national policy level and ensure that community voices, as well as those of the vulnerable people, are addressed. So the platform also, it exists to influence policy. And my brother from Tororo has emphasized the issue of advocacy. So this platform also has an advocacy mandate to ensure that voices of communities and the vulnerable populations and people are all addressed. So the platform does that. And of course, overall, we advocate for the improvement of RMNCH services. Currently, the platform has a membership of over 180 civil society organizations. The number keeps on going high and high, and the platform has membership across the entire country. Okay? So maybe I should have started from whether we actually all understand. The other day, we asked people, what is RMNCH? And we had a very big problem. We all understand RMNCH. My sister Helen, the other person wants you to help them. What's RMNCH plus N? Anonymous. They have sent some signal. Whichever way. Quickly, yes.
Creative one, and then you rotate. I think I like maternal health. So what is your favorite one? Neonatal nutrition?
Yeah, there is N. You know now there are 2 N's, but the N after M.
This one?
Yes.
Okay.
That's neonatal.
Okay.
Neonates. So
Okay.
that could also, someone might ask, what is now what are neonates?
Mm.
What are neonates, for instance?
We shall ask Google. We have got that.
I'll take the A, adolescent.
This is adolescent. Okay.
I'll take the C, child.
The C is the child. Okay.
I'll take N, nutrition.
This is nutrition.
Yes.
Which letter is missing? R and H. Which is reproductive health. Okay. Great. So we are all working in this space. So this is just an acronym of what we have just talked about. Reproductive, maternal, neonatal, child, adolescent health, plus nutrition platform. So it's a civil society platform. We all come together because this is what we do as civil society. Okay? And I've said this is where, this is what the platform is focusing on. And currently we have a membership of over 180 civil society organizations spread across the country from all regions. Next slide. And what is the vision and the mission? The platform has a vision, it has a mission. Of course, it envisions equitable, accessible, and quality RMNCH plus N services and information for all. This is what we envision. And our mission is to build a strong, united, and informed CSO voice with capacity to influence decisions. Okay? These words were all intentional. Around policy, planning, financing, and implementation of quality RMNCH plus N services. So this is what we want to do, to ensure that our platform members are informed, have the capacity to influence. And I think this is why we come here, to share our capacity, by the way, because we know that we have institutions which are strong in some areas and institutions which are also strong in some areas. So when we come together as a platform, we share our capacity and we are able to influence policy and able to hold government accountable on what we have told them accountable. So how is the platform governed for those of us who are interacting with this for the first time? So the RMNCH plus N platform has a governance structure. It's in 2021, which is last year, the platform embarked on a process of strengthening its governance and leadership. And I think most of you remember that we went through a rigorous process of selecting member leaders. And a consultant was hired, and there was a serious nationwide exercise that was conducted online, and you people, the members of civil society, you selected your leaders. Thank you for selecting the leaders. You sent me there also to represent the youth. That's why I'm standing here. Yeah. So the governance is well structured, and so what happened, or what came in as new, apart from us getting the leaders, there was a thought now of splitting up the RMNCH plus N, because we realized that as opposed to the previous years, we were leaving out or not focusing a lot on the various arms of RMNCH. Are we together? Because it is broad: reproductive health, maternal, neonatal, child adolescent health. These are very broad aspects. So we thought, all of us collectively, that there is need to actually focus. And sometimes, you know that if we are to focus, it's always good to break down the elephant into small eatable pieces, right? You cannot have the whole elephant yourself at once. But if you say, let me start with does the elephant have ears? Let me start with the ears, yeah? Then before you know it, the whole thing will be eaten. So we then agreed as a platform to break down the entire RMNCH plus N, and we came up with what we now call forums. Okay? So that is why we are gathered here as the Adolescent Health Forum. We are part of the main RMNCH CSO platform, but we belong to the Adolescent Health Forum because our work as partners who are here mainly focuses on adolescent health. Are we together? So we also have the Nutrition Forum, World Vision, is it called CISANU, and so many other organizations are leading us on nutrition. There is child health, there is maternal health, we have safe motherhood, we have adolescent health here, then we also have persons with disabilities. All these forums have leaders. They have institutions that are leading. Are we together? Great. So the roles were put out clearly. It was a participatory approach. Those of you participated last year, you remember very well. And every forum by now should be knowing what they're supposed to do. And the leaders at least have been oriented by the overall steering committee on what they should be able to do. So we are very glad as a Adolescent Health Forum that I think up to now, the Adolescent Health Forum is the one that is still leading. All the other forums have not yet met, but Adolescent Health Forum, I think, this is the second meeting? Yeah, we're having the second meeting as the ADH Forum. The other forums will be meeting tomorrow. Arafat, the other forums are meeting tomorrow for the first time. So adolescents and the youth organizations are always very fast there. So yeah, this is the background to the governance of the platform. So those who have been asking questions, so how does the governance look like? The platform has, the governance is, this is the structure. We went ahead last year, the consultant supported us to come up with a governance structure, which is here. We have the RMNCH plus NCSO platform and the members up here who are the overall, of course, decision makers as the General Assembly. We then have the steering committee, which comprises of the platform chairperson. Right now, the platform focal person, RHU is the one holding this mandate, and Richard Mujenyi is the one representing RHU as the focal person. We have the platform alternate co-chair. Living Goods is holding this mandate, and Hafswa is the one representing Living Goods. Then we have the youth representative. Naguru Teenage Center is holding the mandate, and Joshua is the one representing here. Then we have the secretariat here, where we have the platform coordinator. I think early in the morning you had someone called Okwi Frederick introduce himself as the platform coordinator. So the platform coordinator supports us to do most of the running around, coordinating us, administrative work. If there's need to write a quick concept and all that, he's the one who supports us. So Frederick Okwi is the platform coordinator. So under there we have the platforms now, the various platforms that I've talked about. Reproductive health is here, newborn and safe motherhood, child health, adolescent health, nutrition, PWDs, we have HIV/AIDS, and there's one that we have not yet added. We're supposed to revise this. SGBV? Yes, the one that Professor is the one that Fomi is handling. Yeah, so this is how our structure looks like. Are we together at that point? Great. So, what are the key updates to date? What is happening in the platform? What is happening in the platform? So I'm happy to inform us that the platform, the way it operates, it is sustained by the partners, okay? And it is the partners who support the operations of the platform. Are we together? This meeting was supported by Plan International and Naguru Teenage Center. So the partners are the donors, okay? Because the agenda that we're discussing is ours, and somehow feeds into some of the activities we have already committed to do. But also, the forum leadership has a mandate of looking for resources, because we know that we have a coordinator who is paid, by the way. The coordinator has to be paid. Forum activities have to go on. We have to build the capacity of our members and all that. So the forum leadership, the steering committee and the forum leaders, we have engaged seriously in resource mobilization. And I'm happy to inform us that we received a grant. Okay? I thought that you'd clap a bit. At least we received a grant of $72,000 from Population Action International PI, and the money is here. The recipient of the grant is PPDR. You all know PPDR. PPDR is the one who has been receiving, is our grant receiving partner for now, and the money is already here with us in Uganda. This grant is looking at delivering on these two objectives. Objective 1 is that by June 2023, Ministry of Health implements key RMNCH plus and CSO recommendations for execution of interventions. You remember during the development of the sharpened plan, we had a meeting, I remember, at Golden Tulip, and together as a platform, we came up with recommendations that were adopted in the sharpened plan. So it is our duty also now to follow up with the Ministry of Health to ensure that these recommendations are implemented. Okay? So through this grant, we are going to be able to follow up on the implementation of these recommendations. The recommendations were on RBF, results-based financing, commodity supply, adult health services, and all that. So we are going to be, we have partners who are going to be leading on this. Yeah, I see some of them are here. Welcome, Sil. Partners, so what happens is that this grant is implemented jointly. There's nothing like a lead partner. It is our grant as members. So we have partners who take on a given objective and they mobilize us as members of the platform to take part in the implementation. So this is objective 1. Objective 2 states that by June 23, the RMNCH has clear, robust, and functional structures for effective coordination and implementation of the sharpened plan. So this objective is looking at coordination mainly for the platform, the structures internally, looking at the forums being functional, looking at our visibility as a platform. You will realize that the platform up now does not, we have online platforms which are there, which are there, but we are looking at developing a website, having very functional online platforms which will really communicate the good work that we are doing as a platform. And this grant is going to support us to do this. And through Objective 2 also, we are going to support all the forums to meet and have their regular sittings. So this is what we are going to do. Part of what we are, of course, there are several activities under there. I've just given us a snapshot of what is going to happen. And I know that in the subsequent meetings, my colleagues will be sharing. And I don't know if Okui is still online. Okui, just in case I forget anything, please feel free to air it out. So this is what is happening, and it's good news for us as a platform. But also through the coordinator, we are sourcing out for RFAs. We are trying really to raise money so that we're able to sustain our activities. We know that Plan International has given us money for today's meeting. Naguru has done, but how sustainable is that? Okay? So if we can get enough resources to sustain our activities, I think it will be a plus for us. The more resources we have, the more work we shall be able to do. And then there's an annual general meeting that is coming up, and you're all invited for this meeting. It is for all of us to attend 29th of September. We're having an annual general meeting. So for all member organizations, please, please, please be sure that you attend this meeting because it's important. You are the highest decision-making body, like you have seen on the structure. We request you to be part of this meeting. The venue is going to be communicated by Okwi, that we have already scheduled it for 29th. We request that you send representatives. And we shall be making more, giving us more highlights in the AGM, making some key announcements, and also with your guidance, we shall agree on some issues that are going to help the forum to move forward. We have also scheduled forum meetings, like I said earlier. I think apart from the ADH forum, which is very, very vital and functional, the other forums will be meeting tomorrow. But I know that there's also space again for the ADH forum, which is meeting today, to meet tomorrow. A meeting has been scheduled tomorrow at Kabira Country Club, somewhere in Bukoto, for all forums to meet. The forums are supposed to meet and agree on their roadmap, because in the AGM, we must have clear updates from the forums. So space has been provided. Partners have already invested in money for the forums to meet on at Kabira Country Club tomorrow. And I know that some of the decisions are going to be made here. Arafat and the members who will be around tomorrow will be able to share with the other forums. I'm sure some of you have received emails from some people inviting you for a meeting tomorrow. Yeah? Yes. Then there are other key activities that have been scheduled for the platform, but even for the ADH forum. Okay? I think a few months ago or 1 month ago, I think we had members of this forum were engaged in a training at Admas Hotel in Entebbe, if I can remember well, where we came up with an action plan. The training was on social accountability, and we developed an action plan. We agreed that we are going to train our regional youth leaders and all that. So I'm happy to inform us that the resources to implement part of that action plan have already been earmarked. Yeah? Hey, now those who are not clapping, it is also okay. You wait when you come here and we also don't clap for you. Yeah, so the resources to implement that, the action plan that we developed have already been earmarked. And so the regional leaders trainings have already been scheduled. So some of you are going to be contacted by Arafat to participate in that activity. Yeah, because it's part of our capacity building. You read from our mission. We want to build capacity of our members in advocacy, social accountability, using the smart approaches that we have been utilizing. So the forums, specifically the ADH forum, will be going out to the regions to meet with the other youth leaders or youth-focused organizations. And they will be delivering the trainings. So also, with funding from World Vision, the platform has embarked on conducting regional dialogues. The regional dialogues which are ongoing right now. Yesterday there was one in Gulu. Yes. So the other one, I think the second one is going to be in Fort Portal for Western Uganda. So we have all these activities going on and partners are supporting them. Regional dialogues are engaging our member organizations and still engaging them on the issues of the platform. So that is, I think, a quick snapshot of what is happening. Arafat, have I forgotten anything? Anyone, any forum head here with any update that I've forgotten? Yes, but also maybe quickly to mention, and it's going to be addressed in this meeting, that specifically for the ADH Forum, we all know that the ADH Forum has gone ahead to develop an advocacy roadmap. Now, because I sit at the steering committee, somehow I know what happens at the ADH Forum, and somehow when we sit in the steering committee, I ably give feedback to the steering committee on what's happening down with ADH Forum. So the draft forum roadmap was presented to the steering committee, and it's aware of what the forum is doing. So the roadmap was sent back for further review and input, and I think it's a process that we are going to finalize today. And I request that when we start on that process, if you have been dozing or busy on your phone, tweeting, okay, WhatsApping, please, the roadmap session is very, very important for us. Okay? If you are not doing something very, very constructive on the phone, focus on the session. Then I will take us through that session. It's very important because what is going to inform what the forum is going to do in the next phase of business. We already have a draft, but we want to finalize and agree. And this document is going to be presented to the steering committee and then be presented at the AGM. So it will be a living document that will inform our business for the next 1 year. Okay? So if you have interest for the politicians who are here, please make sure your interests are handled. Yeah? And the opportunity is now or never. Don't say that, sorry. That's why we even made sure we bring high-end technology. Those who are on Zoom, at least are also following. Ladies and gentlemen, so that is a quick presentation about the forum. Does anyone have any question to that point? No questions. No question. When students keep quiet, two things have happened.
There is one here.
Yes.
Thank you, Josh. Maybe also you need to inform members, of course, some of us know, the terms of reference very clearly. I think that is what we did. We must ensure that members understand what is their role. So in addition to that information I've given the members, I request that also you talk about the terms of reference for these members, because sometimes the members might join and do not know what they are supposed to do. They look at it as an agri thing or plan thing, whatever, yet members have responsibility. So maybe you can expound more. I know you should have been in your presentation, but maybe give a hint about the terms of reference.
Terms of reference.
Yes, yes.
Very good. You see, that's why I love Raymond. Raymond will remind you when you forget something. He's a very sharp man, even if you wake him up at 1 a.m. So thank you for the reminder, my brother. So terms of reference, actually we had an agenda item on terms of reference, but we thought that the agenda was getting so packed. I think it's one of the things that we got out of the agenda the other day. But it's very true, we have terms of reference, and I think we're going to share out a document. And I request us members, don't be members who only come for meetings when they have invited you. If Arafat sends something that needs our input online, let's be active also online, because it's expensive for us to come here, okay? And yet we have a lot of work to do that we may not necessarily deliver on in a meeting like this. For example, terms of reference documents may be sent out that needs your input and your, please give input. The other day, he sent out a document with a link. I saw a word, click here. The word here was highlighted in blue. I don't know how many of us clicked there. You see? But the document is going to be shared. Now, there's the other thing that I need to make clear to partners here also about, so it's actually a resolution that we made as a steering committee, and the members need to know about it, so that we don't think that this is a planned thing. They are just inviting us here to pass the agenda. No. This is our thing. And there was a question that came out. I know that some people are not asking, but it may be somewhere in their hearts about the branding and visibility of the platform. How is the platform branded, and how are we ensuring that it's visible? And actually, it's one of the interventions we're having in our new grant. As a platform, we want our work to be visible. The donor also wants us to make sure that they are visible. And moving forward, in whatever work we are going to do under PAI, we are going to move with their logo. The platform has one logo also. You've seen it, it has pink on it. Now, we also agreed that partners, if a partner supports a meeting, okay, we have their logos appear on the materials for that meeting. Okay? Because it is accountability for them. It's accountability to the donor. If Plan has given us money for this meeting, it's only good that we have their work visible. Okay? Because they are donors, you need accountability. If Naguru has given us money, those are practical examples for this meeting. Naguru has given money, UNFPA has given money to Naguru to deliver. Then tomorrow you tell the UNFPA that our logos didn't, it might cause trouble. And the same to Plan. So anyone who will give funding to platform activities, your logos will be all over the place. But for the grant that we are going to implement under PAI, if the money is purely PAI, it will be RMNCH logos and PAI logos. Okay? And that's how we are going to move. We are together? Yeah. And for joint, we have done a lot of joint activities also. I think where there is investment, that's how we shall be moving. But the detailed terms of reference document is going to be shared out, and we shall request that you all give input to that. Okay? Yes. So, the other item, now that I've answered the questions, we are supposed to agree on also leadership for this, and this is going to be participatory. We're just going to brainstorm together. We shall get the ideas, and we shall document. We're supposed to give me 3 minutes only, and then Diana will come. We're supposed to agree on a leadership structure, on leadership for this forum, because we have the main steering committee for the RMN CSO platform. The steering committee has 3 people: the chair, RHU, the co-chair, Living Goods, and the youth representative, and the coordinator who supports. Then we have the entire committee, which now has the forums. But the forums are represented by organizations. And realize that the work that has to be done is quite a lot. Adolescent health is not only a Kampala issue. It's not only in Bugorobi, where, whichever communities you have come from today. But we have people in Kamuli. Mudumba Charles of Hold Uganda is in Kamuli right now dealing with teenage pregnancy and Vasoga there. You see? How do we bring those people on board? How do we bring Kasese? I come from Kasese. I have to talk about it. Hey, it's my brother. We are 2 of us, serious advocates. Our people are there. We have climate issues, which is now affecting SRHR service delivery in Kasese. How do we bring the people in Kasese to this forum? So that's what we want to agree. Arafat is our leader, but Arafat cannot do this work alone. You will agree. So we want to get your thoughts to this. Okay? In 3 minutes, if I can get 3 hands. And whatever we are going to agree, it has to go upwards again to the steering committee so that we give them our thoughts, our resolutions. The committee will agree. We present at the AGM on 29th, and we get rolling. Yes, Raymond.
Okay. You have yours?
Yeah, thank you, Josh. I may not stay longer. I thought I would speak and then I can leave. Or after. Being that we are putting an institution, a structure, which must be sustainable and ensuring it is partner members led, I was trying to look at how do we ensure that we make this as a structural organ. And one, that's why I came to ask about the TORs, because they are very key that members must appreciate that this is their thing. We must come up with a constitution to govern this structure. These are important instruments to strengthen, or let's call it constitution, or a guiding money or guiding tool to make this program, this structure work. I mean, when I say constitution, I might go into NGO world, but something to guide its structure to operate. Two, and then come up with a framework. Who are the members? And I was proposing, and I'd put something here. We can have a 9-member team, including the chair, the vice, the treasurer, the secretary, and the 5 members. Those are 9. Or you can choose. But I'm just thinking, basing on the fact that you need to move, because the other groups are getting there. They are moving. Chair, vice, secretary, treasurer, and the 5 members. So just thinking. But this is usually not to be odd, whether 7 or 9 or something. And then these ones will be structured in that, the other document I mentioned about earlier on, how you are going to operate. Having those responsibilities, the terms of reference clear there. The chair, what is his or her role, and the other membership. And then you can look at this, now that this ADH is a national related forum, you can regionalize it, ensuring that the members, the 5 members, for example, are coming from each region, representing the members they're in, and ensuring they're inclusive enough to have all categories of young people and CSOs reflected, whether disability, whether HIV, and the rest. I'm just trying to ensure that we move this, because the other fora are ahead. Us who are still, and I know he would have said that earlier, we need to support the team to ensure that we move. So I guide that maybe we can look at that as a beginning. It guides our structure, and we support the members that will be elected. Those who attend tomorrow or the other day, then represent this as part of our beginning team to ensure that they start roaring, because the grant is time bound, and ensure that it must have a structure moving. So I wanted to support that on that. Thank you. Someone has a hand here as well. I'm not a chair. I'm not a chair.
Okay. So I just want to again pick from where Raymond stopped. So I'm viewing this whole thing as some kind of a governance or government something structure. So I'm thinking of a secretariat, for example, at the national level, because also we must be cognizant of the fact that we are going to deal with a lot of operational issues within this area. Then perhaps at the regional level, we also have another team, another sub, at regional level, so that what we decide at this national level informs the discussions at the district level. It can be in either by region or even at district level, so that we're able to trickle down issues that come from the national or even bottom up from the region to the national level. Thank you.
Thank you so much. Actually, if I'm not mistaken, all what they are saying is very right. However, we need also to look at the districts. If you want to capture all the indicators that even Olivia talked about, also districts at a district level, it is also very key, because there are districts that are not balanced. You can't trace, you may trace at a regional and you capture 2 districts. And yet a region has a number of 5 districts. And how do we meet the other gap? And yet to come to realize that there are key issues that are affecting those other districts that we have not captured. And maybe no partner is going there due to resources. And how do we support those districts? And yet there is more of mortality, maternal and child mortality rate, and also high impact of teenage pregnancies. So we should look at look into that as well.
All right. Yeah. We don't know if we have any members online, but Mr. Chiveru can project and see if we have. Rose has disagreed with your agreement.
Yes, I'm really interested to know that you are, and also I wanted to find out if that you covers the membership of the fora. Is it institutional, organizational, or individual members? Should it be individual, or there are also other interested members that are not in the institution that should join the fora?
Thank you, Rose.
Okay. Do you have anyone online? There are 17 people left.
Okay. The man from the village.
Please, online members, you can raise up your hand if you have any. As part of the structure.
Can I go on or I wait for the online? Sure. Joshua, can I go on? Oh, okay. Leadership structure. Yes, I agree with. I want to agree with the speakers before. Raymond talked about a 9 leadership team, but I was looking at, Joshua, since you are a member of the steering committee, and if we are to have maybe make a proposal that other forums could also buy in, my thinking is that 9-member team, when we would have a steering committee on top, would be quite huge, because would look at an extent where leaders of forums need to meet, and it's not quite a very big conference for the leaders. I would think of a 5-member team, but factoring in regions would be at a point when there has been, I don't say mapping because mapping was done, but trying to have more members in different regions. Because as we speak, this RMNCH is mostly your Kampala thing. There are just a few people who have actually tried to who are coming from the villages. And even when we come on board, not because you have sat in the forum meetings and given opportunities for people to speak from, or given findings from different communities. For example, in these forums, we would be looking at, we are having a lot of things going on in the villages. But apart from you watching them on TV, and then we come here and have some sausages, we need to have the members identified and brought on the forum. That should be part of your TOR as a member of the steering committee. So when we come to the ADH here, forum, now like for example from Butaleja, we are here, but we know of different members who could be very important for the cause in the region as Bukedi or as Eastern Uganda. Let's say Bukedi, for example. But like you said, we can't do this work alone. We need your support. We need to move together, the team, have them, because it's an advocacy. We need the numbers. We need the team to build and move together. So the regional thing, I want us to put it there that we need to bring on board different members before we can regionalize things. For the leadership, 5 members would be okay. We have the chair, maybe a co-chair, or we could even replicate the leadership on top, but just having something that is workable. And if you are meaning about leadership, are we also talking about issues of the real work? Because leadership is just basically direction and governance. But when you say Alphat cannot work alone, are we looking at leaders who are also going to work with the Alphat in terms of the actual work, day-to-day running? Because we'll assume Alphat is not just a chair, but it's also like a secretariat of ADH. So are we looking for other secretariats to support this secretariat, or we are looking for people who are just going to give us the brains in some way. That's my contribution from the village. Thank you so much.
Okay, now that we have got the contribution from the village, I think we agree that the village is also represented in Kampala. So the village has not been left out. Yeah. Okay, can we now, okay, very last submission, and then we shall agree.
Thank you, moderator. Maybe just to respond to someone who talked about the TORs. Around 2018, Diana, she's on. So maybe someone was asking about the TORs, and around 2018 we had designed the enhanced civil society engagement strategy. I remember it was supported by World Vision. By that time, World Vision was the focal point agency for the platform before it went to PPDRO, and Esther still was the focal point person for the platform. So we had that engagement strategy that was elaborating clearly the roles, the principles, the processes of engagement, how the platforms are, the forums are made or people come up with, and how we should engage different actors, both in civil society fraternity, but also in government or other NGOs or agencies. So it is there, it was running 2017 through 2022 October. So I'm thinking that the coordinating team for the platform that is led by Okwi, or Richard, as well Esther from Path, Nasiche, could help us with engagement strategy. Perhaps someone would come and present it such that we know what we can input, because if it is still stands that it was supposed to run 2017 through 2022 October, then that means it is almost due in the coming month, so that we could see how we can update it. But also there are some stuff that are evolved over time. For example, by that time nutrition had not yet included into the platform, but now it is there. Also even other populations that we have, even within the platforms, we have key populations. We have female sex workers, we have like diversity that it should be appreciated within this enhanced civil society engagement strategy. So I'm thinking the point here should be how we can update it such that it can be accommodative, but also appreciating the phenomenon of intersectionality. Yeah, so maybe that's what I can respond to you. So the starting point there should be on revisiting the civil society engagement, enhanced civil society engagement strategy that was for the platform. Then we can see where we can have the TRs coming in, how people should be engaged, the leadership, because also it has the steering committee, when should be elected, for how many years, who should be engaged, and all those processes are there. Yeah, thank you.
Thank you so much. Very, very brilliant brains in the house. Okay.
Can I say something, please?
Yes, Bridget?
Hey, Ndagan, yes.
Thank you so much. Joshua, that was a very elaborate presentation, regardless of the questions. I think what I'm going to share is may be a bit cliche, but when we're talking about governance, what I want to see more is engaging adolescents in this case, not just as beneficiaries, but I want to see in such a room, where is the adolescent you're talking about? Not just the adolescents in Kampala, but the adolescents in the villages, the places you're calling villages. Where is the adolescent? I think we are past the era where we are sitting and making decisions for them and think we are in a better position to do the governance. I want to see more of that, and not just at this level, but also in the districts, in the communities. I think right now we have, based on the work that we are doing, and I mean, just so you can back me up as an abortion center, but also because of the work we are doing, we are seeing adolescents being empowered, and there are different networks at the community level that really emphasize engagement, meaningful engagement of adolescents. I want to see that in such forums, besides us sitting here and talking about governance, without them being part of the process and looking at them as just beneficiaries of our services. Thank you.
Thank you so much, Bridget Ndagano Juko. Now, she brings up a very, very important submission. Where is the adolescent? Because we are Adolescent Health Forum. Where is the adolescent? Okay? So even as we talk about coordination, as we talk about having a committee, I think we have to ensure that we have their docents on that coordination structure that we're talking about. Great. So thank you everyone for the submission. Like Arafat already was it called prophecy? He mentioned that we'd have a late lunch. I request that you hold on to the hanger. If you need another cup of tea, please, because we need to finish the next session. Diana has to take us through the last session before we can have lunch. So can we agree on this, and then we shall ask someone to clean it up, and they will share it with us again before it is shared with the steering committee and AGM for adoption. Okay? But I think what seems to come out for me, okay, Helen, you're the one who was writing. So can you tell us what you have written and take us through the way forward?
Thank you, Joshua. There have been a lot of things. I think some have been captured twice, but key is what the last speaker talked about, that there should be representation of adolescents. We've had 2 suggestions from Raymond and another gentleman in terms of should it be a 9-member committee or should it be 5? And there were one of the key things they're looking at is someone asked that committee and the leadership, are they from the technical wing? Are they just governance? When we say we need someone to support Arafat, is that in terms of technical support or just governance? And I think that also just captures representation. Key to this leadership and the TRs, because I think they've been discussed interchangeably, the leadership and the TRs, and I think it's from you, Rose. You mentioned that are people aware of these TRs, and I think your communication also spoke to effectiveness, implementation of them, where then you talked about the engagement structure under the CSO, and you say it was supported by World Vision. So there is need to look at it, update it, and enter new ideas. And you mentioned the idea of nutrition, but also intersectionality. Then under criteria, someone asked something that I thought was very key, that other members, are we looking at individual advocates, individual members, or are we looking at institutional representation when we're looking at governance? So just to throw it in the wind. And I think, oh, all right. So I'll have to give you, we discuss one and answer them in green, eh? So we could start with the type of membership or the criteria, that should the people be in, can we have both? Can we have one? How do we go about it?
Okay.
All right. Doesn't seem to be sorry for the Zoom people. So the question is, in terms of criteria or the members, someone had asked, should we have individuals or institutions or both? We hear both. Joshua, were you looking at us putting this to a vote or just a few suggestions to mull over? Carol, you look like you want to suggest for us here. Not yet.
Thank you, Joshua. If you looked at your introduction for the platform and you're trying to break down the forum, I think it had all categories represented. So I would still want to go with both. Thank you.
Okay, we have both, and the reason is that that's part of our MEMATs, part of our constitution, from what Joshua provided. So, Joshua, you had mentioned the institutions. Is there a specific reason that you want us to?
Okay, yeah. So again, to take us back, this is whatever we are discussing here is going to be affirmed upwards. And again, we're not diverting from the constitution because the bigger platform already has a constitution. Okay, so we're just feeding into that. Yeah? Now, whereas the Constitution talks about individuals and CSOs and all that, mine was just a thought that we look at CSOs here. Why? Because I think at this level of the ADH, of the forum, we are looking at delivery of business, really, yeah, and sustainability. I don't know how it would turn out with individuals. I don't know, yeah, but if the House thinks that we go with both, then we'll take that.
Hello, this is Membo from UNHCR.
Yes.
Can I continue talking?
Yes, Membo.
Yeah, I would thank you so much for the presentation and for the discussion that I've been keenly following up. I would just agree with you, Joshua, that we might need to maintain institution representation, not individuals. Then the individuals would come at the intervention level. If we have some activities, then that's when we bring in those adolescents at an individual level. But for this, for even proper follow-up and accountability and governance, it's better to engage institutions, not individuals, because they are able to be held accountable and to make some decision and take them on. That's my suggestion. Thank you.
Thank you so much, Mebo. Great. I think we agree.
Yeah.
Yes. Even those who have kept to know will have said yes for you. Those who have kept quiet, sorry.
Yeah. And maybe to provide clarity that this is for the leadership, the governance team. So, yeah.
Joshua, mine is also a follow-on question. If we are taking institutions, what type of institutions are we taking? Are we looking at adolescents or youth-led organizations, or all organizations that are interested in adolescent health?
We are looking at member institutions that are members of the ADH Forum.
Yes. Okay. Members of the ADH Forum, because if we look at the governance, then that also should be coming out very clearly from this meeting. If we agree it should be members of the ADH Forum, well and good. Yes. I just wanted it to come out clearly. When we are capturing the notes, that is also well captured.
Okay, so the criteria for which institutions, we've gone with the institutional, and the reasons they've given is that it's easy to fundraise with them, sustainability, accountability. But Arafat asked that what type of institution, and from your presentation I capture that we are looking at members of the ADH. Okay.
Thank you. I wanted just a confirmatory question. Is everyone in this forum right now, right here, now? Are we all of us members of the ADH Forum?
You are not a member of the ADH Forum, please.
Excuse ourselves.
Yes, the invitation was sent to members of the ADH Forum. Yeah. And my assumption is that everyone who is here is a member of the ADH Forum. So if you sneaked here without an invitation, please leave the room. But I think we are all members of the ADH Forum. Even by scanning around, really, we are all members. Yes. And again, we know by virtue of the work that we do, sometimes our work cuts across the RMNCH plus N. Yes. Now, we discussed that because people are asking, members are asking, so where should we belong? World Division said they do nutrition, they're in adolescent health, they are everywhere. So we asked them, what is your core? Because every institution has its core. Yeah? The niche, that's the right word. Thank you, you went to the right school. The niche is where you fall. Yeah? If you think your core is in HIV/AIDS, the niche, then you go there. But those of us who are here, our niche is in ADH.
Okay, thank you. I think we've moved on from that. If we haven't, we can always pack it somewhere, you write it, and then we come back to it. So we go to the level of representation. Someone had suggested that we look at subnational, which is district. Don't know if we want to break it further to sub-county or parish, but subnational and then national. They talked of regional, but I imagine that this regional is just after subnational, not the East African region. So yeah, so we have subnational, regional, and national, that we have representatives from here. So the thing that we can add here is, I think Angela or someone online talked about it, is ensuring that they are adolescents. Bridget, adolescents here. So what say you, what are your thoughts on this one? And how would that look like in terms of this subnational, which districts, which regions?
Yes. Opio Stanley, you are the one who should answer this question. The question on because again, if should it be district, sub-county, regional, subnational, that languaging, please help us. You have been in these things longer than us. Regional.
That's the region. Wanang. It is the region, right? Subnational, the region. You have the national level, ADH national. Then you have the subnational, which is actually the region, Eastern, Bukedi, Western, and blah blah. Yeah, district is now a combination of.
That's the subnational. So subnational would be, do correct us if we're wrong, is district level. No? Okay.
It's
so
region.
We're looking at subnational with regional. No? Gentlemen, okay. Are the same.
I don't think they are the same members. Yeah, they're not the same. Okay, I'm mirroring the Adolescent Health Forum that sits at the Ministry of Health every month at national level here. Then you have, for example, West Nile. They have there also Adolescent Health Forums in West Nile. In one district, West Nile has Arua, Nebi, Zombo, blah, blah. They come in one space. That's really that.
And that would be regional.
Yes. So, I think that's why I ended. To think.
Okay, so we have it at subnational. If we have, for example, a subnational representative, for example, West Nile, subnational representative West Nile is maybe Kea, for example, because they are working in that region. So they will support us to coordinate the partners in that region, so that for us, we again don't have to go down to the sub-county. Right?
That is what we call the region. Then the subnational is a district. Yes. A district within a region. Yes. So when you say that you're going to hold meetings in Western Uganda, and then you sit in Imbara, that means we have subnational. So if they coordinate all of them, Imbara, if it coordinates all the districts within Western, then that is the regional meeting. But if you want to reach in Western Uganda and you go direct to Bara, then you're dealing with subnational.
You have understood? I'll bring the pay slip. You need to pay school fees. Thank you. Thank you so much. People need to understand that. Yes, fine.
I need to be helped. She has given an example of Western Uganda. Because when you go to Western Uganda, you have Ankole, you have Chigezi, then you have Rwenzori region. So how do you define that? Okay. Yes. So
no. Okay, colleagues. Now, let me guide the meeting. Now, depending on where you come from, this country has been regionalized in so many ways, depending on your background. I know that someone is about to tell us health sub-regions. Someone from government just will tell us that no, we only have Western, Eastern, West, Northern. But in health programming also, we know that the regionalizing is different. Now, also in our cultural perspective, we say we have Rwenzururu, we have Toro, we have Kabarole, what, you get, eh? So we are going to confuse ourselves. Let's agree. I think in the CSO programming, we have followed the government regionalizing. Yeah? We have followed government regionalizing, where you have the Western as Western. And again, depending on what you are implementing, sometimes you break the region into two. Western region, some people go to break Southwest, depending on what you're implementing and your donor. So, colleagues, I want us to move forward so that we get off this issue. The issue of regionalizing, colleagues, because of time, let us agree that...
Just I was suggesting before we agree that we also have regional youth representatives. If you could look at the catchment of the MPs, the regional youth representatives, we look at their catchment and then it helps us sort of agree on the representation.
Thank you. So, colleagues, I think we are agreeing that if we have a region, we used West Nile as... No, we are using an example. Okay, Western Uganda is a very big region. If we have a representative of Western Uganda, then the Western Uganda representative, whoever it is, an institution, I don't know who is strong there, then they will have the mandate to coordinate us in that region. Okay? So it is, for example, Rahu is doing a lot of work in Western Uganda. We say maybe Rahu Western Uganda. So it's their mandate then to coordinate the partners. Then they're the ones to go downwards. Please don't define region and sub-region and district. We shall go backwards. Colleagues, time.
I hope this particular discussion of structure is going to also be implemented in the funding that we are anticipating. This is what we should do. I'm not ruling, but from my experience working at the grassroots, we can have the leaders, regional leaders representing, who are responsible in feeding into the national body. At regional level, we're discussing here, for us who have worked at the grassroots, Joshua, for you just come to Taleja and you sleep in Bali. But for us, we sleep there. Now, at regional level, what we can do, we can create some committees. For example, if we're in Eastern Uganda, we can have a representative from Busoga, Bukedi, Teso, and all that. Now, at that level, the region, we can have also the committee, and that is the committee that the leader, or the content of that committee, the leader will transfer to the national level. But this also requires you, Joshua, as a steering committee member. I don't see you as a member of the ADH, but from there as a steering committee, that you have to actionalize this. You have to actionalize this, that at regional level, they are meeting to support. Just the way you also want to be supported at Kabila, you should also support the members at regional level. Otherwise, we cannot have each sub-region a leader reporting to national level. But we can have one person who represents the other leaders at regional level. And this person here should also be supported and given a mandate to engage the other institutions at regional level. In that TOR, we have to also be skeptical and also be careful. World Vision works almost everywhere in the country. So where are they going to belong? Is it in Eastern Uganda? How do we work with the national and international organizations at program at regional level? The members of the institutions that have different offices, and say World Vision Kachonga is in Mutaleja, would be a member of the ADH Forum at regional level, and not at national level, something like that. Do you understand me? Okay, thank you so much.
What was coming up, it's like regional definition of the region we seem to have many definitions. But you rightly said, as far as health programming, there are regions. So I think what we need to know is that we need also to look at the studies that have been done, like UDHS, and that is what has informed the Ministry of Health come up with regions. So we need to be very clear. There are regions, Western Nile, that is standalone, Central region, Central, there is Central 1, Central 2. Let's just use those regions to define our regions. That's what I would submit. Thank you. And I don't know whether I should, there was an aspect of subnational, but I think that is really clear. Something which is below national is subnational. So in terms of, I think without necessarily going a lot of, I would think that the structures that Olivia talked about can do coordination at district level. And then you have those ones at regional level. I think that's my submission. Thank you.
I think we've moved on from that. So we have district, regional, and national, just for purposes of time. And maybe, so here, we have not made a ruling here on what specific regions. Should we say that the action point is that we go back and look at data to choose our regions, or should we select the 5 and say these are the regions, Eastern, Central? From here, we already know which ones. So we take the 5 regions. Okay, perfect.
Joshua and Helen, just time check. We have 12 minutes to lunch. So we are doing bad to our next presenter.
Yeah.
Yeah, going forward. Then, following time here, members, I mentioned the 5 members because of those regions which government knows. We are headed to know regions because I was still Karamani as a region. And you can't complain because we work there. Altogether, those are known. But for now, let's use our 5 we have. But now, let's get our leadership. The chair, vice, treasurer, and secretary. These guys are going to present to the main group. This is tomorrow. These guys are going to present to the, this tomorrow, right? Friday. So they must have a structure stake there that which will be a replica of the other sub-fora under the Ramnak plus N. Are we together? So let's take a little time. We'll get our leaders, and then we'll have a structure. The 5 we're talking about, those will be for the region presenting us. The other things we can handle, because after here, we know we need to do a mapping to know who is doing what in those regions. What? Are we together, members? Let's take a little time. We get our leaders, and then the members can discuss with the main team on Friday. Thank you.
Thank you so much, Raymond.
Just a quick one. Do we want, so we've captured in terms of diversity, we've captured, and for lack of a better word, I'll say diversity, but broader than that, we've looked at adolescents, we've looked at regional representation. Do we want to talk about gender representation, or should we just go with whoever comes? Whoever comes. No? Okay, so at least we know we are disability inclusion. We must apply gender lens. So we have a gender lens, we have a PWD lens, we have adolescents, and we have regions.
Good. And that said, colleagues, I would like us to agree. We're not going to vote these people now. What we are working on is a structure that we are taking upwards for adoption. Now, when the AGM assents to it, we shall now come back and we cast our votes, and we shall have the Uhurus and the likes take on their positions. Okay? So, colleagues, can we agree that Helen manages this assignment? How many of us are saying it's okay for Helen to take on this assignment? All of us. And all of us means all of us. Thank you very much, Helen, and she has accepted also. Let's clap our hands. So Helen is the program manager at Rahu. Those of you who don't know Helen, very powerful woman at internalizing things. So we request that you support us.
Okay, but
no, you just, so she's going to work on the document for our leadership structure that then we shall take upwards.
Okay, I think if we are finishing at 1, if we're finishing at 2, then I can be able to share it by 5. Yeah.
That level of efficiency is from heaven. Please clap. At 5 p.m., that is serious. Ladies and gentlemen, thank you so much for listening to me. And thank you so much, Helen, again for offering the support. Okay, so Arafat, I think I've delivered on the assignment. We can now...
Some more hand claps for Joshua and Helen. Thank you. Just a clear indication that we are not yet hungry, given the hand claps. So we request for some additional minutes. Just after Diana has presented, we shall comment, give feedback, and then I'll request that we take a group photo. The people online, good enough, some of you had activated your videos, so we shall be happy to see your beautiful smiles online. And then as we are getting out after the group photo, our colleague Victoria behind there will be having our lunch coupons. The rest of the logistical announcements will come after. So I was trying to buy time for Diana. You know, she's a very busy woman. While she was attending this meeting, she had 2 other online meetings, one on the phone, another on the laptop. Then Stanley was also having another online engagement. Yeah, so that's the CSO world we are living in.
Thank you, Arafat. I think this is a very simple assignment. That document on the screen, I don't even know where to stand. I want to, I think I can stand here. That document on the screen, so, okay. Joshua will help me scroll. Who is helping? That document on the screen is it's a draft advocacy priorities, or you can call it a roadmap for the ADH platform. It was put together by a few people, and we are presenting it here to have your input, you know, before it is considered as a roadmap or priorities for the platform. It is clustered under different objectives. The way you see it, we have one on awareness creation on ADH issues. We have another one on capacity building for the ADH platform members. We have another one on accountability, on strengthening national and local coordination and accountability. For the ADH outcomes. There are 3 areas, you know, that we are looking at as the ADH platform. However, this is just a draft. The reason as to why we are here is to put our heads together to have a beautiful advocacy roadmap or priorities for the platform. Maybe at the bottom of this document, they reflect the different strategic shifts for the RMN CH plus N sharpened plan, which are 5, and take note of the word revised RMNCH strategic shifts. So the first one is emphasis on districts in high burden, emphasis on districts with high burden what? Districts? That's not good English. Then the second shift is increase access for high burden population, then delivering evidence-based high impact interventions, then addressing broader multi-sectoral contexts, and strengthening mutual accountability. So the objectives looked at the different shifts, the interventions that are proposed under each objectives. We are looking at the different strategic shifts as presented in the sharpened plan. I know that you people are well familiar with the sharpened plan because the development process was very participatory, and I'm sure young people in this room have participated. But if you have not participated in the sharpened plan, it will be important for Arafat and Joshua to share with the team the approved sharpened plan that is informing our advocacy priorities as a platform. We don't have a lot of time, and I thought we would, for example, on our desks or in groups, try to look at each objectives and discuss and provide input, the best input in each of the objectives, and then we have them presented, and then we have the team, Arafat and Joshua, to amend it and share back an amended document, and we will consider it as a final roadmap for the platform. Probably we can even have more input from the other platforms. We hear what they say about our advocacy priorities or roadmap, and then we could sign it off as a final framework that is going to guide our advocacy interventions, both at national and Joshua, you said subnational? Both at national and district level. I don't want to confuse people. There are countries that use subnational, there are those who use local government, district. But I think here we are used to either district or what? Or local government. So both national and at the district level. So I don't know how much time we have, Arafat, for us to form the groups, or we can discuss as tables.
Given that you have suggested groups, or in our tables, I think we can work around our tables.
We can work around tables. So we have three outcome areas.
Yeah.
One is looking at, the first one is, let me see, awareness creation. The second one is capacity building. The other one is coordination and accountability. However, you're even free to propose other objectives if you feel the ones that we have are not good enough or comprehensive enough for us to achieve our advocacy objective as a platform. So I think we are going to, any idea?
Carol was disagreeing with working in tables.
Okay.
She was suggesting, given the diversity, we should break down to groups.
Okay.
I'm looking at the time we have to break down to groups. If it's agreeable, then I don't know.
I think the groups, they're easy. They're 1, 2, 3. That's a group because we have through objectives. In the middle here, they meet up. And then this one here, they meet up. So we have the other group looking at objective 1, this one, this row, objective 2, and this last one, objective 3. So let's meet up and use about 10 minutes. Yes, let us use 10 minutes to just dissect. Let us bring our thoughts, to the interventions that we want to do as a platform. But I think it is important that we also, as we look at the priorities or the roadmap, it is for us to, first of all, appreciate what the platform, the role of the platform, or the TORs of the platform. But also you can look beyond the platform and look at as institution, because the platform may not be in position to do things that are going to be done at institutional, level. Yeah? Yes. Do we have a printed copy? Oh, we are working with soft copies.
Yeah.
Okay. Yeah, so we can just meet up. So Is that the center? Okay, fine then. So can they come here? Oh, okay, fine.
Our colleagues online can look at the entire document.
Okay, our colleagues online, you can look at the entire document. You can share your comments either through the chat box or as when we are submitting, you can raise up your hand and give us your thought about the entire draft roadmap.
Okay. Members, we have 10 minutes and I'll be counting down. Uh, Dear members, we have an additional 2 minutes, so we can work within that and present in the next few. The timekeeper is back. Colleagues, I request we reconvene. I know some of us are fasting, but Madam Chair. We okay. Diana, are we presenting from our groups, giving remarks? Okay. Which group feels the entire... Vicky is taking notes for the entire meeting. Vicky. But, yeah. Ladies and gentlemen, I'm going to give Sembatia. We are starting our presentations to Kahira and the group. So we are starting with the group over here. We don't know their group name, but they will introduce themselves. Rose. So Rose is going to present first, and her group. Group 1, eh? Yeah, group 2, group 3. Okay. So over to you, Rose, and I request the other groups to listen in. Sembatia. Consent mwagirabye.
Okay. Arafat. Okay. Our objective number 1 was to generate evidence for increased awareness and understanding of ADH issues amongst key stakeholders for appropriate decision making, and the outcome it is on the document that was shared. I want to I'll just mention the outcomes for this. Objective 1 is to increase the awareness and understanding of ADH issues among the key stakeholders, and objective number 2 was to outcome number 2 is increased evidence-based decision making. And some of the activities that we think should be done on this is annual research on adolescent issues, that is teenage pregnancies, GBV, maternal mortality, and we think the person responsible for this should be the ADH members. And then activity number 2 is documentation and dissemination of research findings. This can be in visual, audio, or written documentaries. And then activity number 3, we say developing and dissemination of IC materials using different platforms. It can be print and social media. And then radio talk shows, dialogue with young people, and then focused group discussions at regional and sub-national levels.
And this includes some of the things that they had already given us, so we are just adding on what we think needs to be added. Thank you.
So group 1, we request that you share that document that you've worked in. Yeah. And group 1 is requesting for you to clap for them. Were you requesting me or the group? Me personally. All right. All right. We've captured that, and please share. Then we take clear notes. Group 2, who is presenting?
So group 2 was looking at objective 2, that looks at to build capacity of RAMNAC ADH Forum members in lobbying and policy advocacy in Uganda. Outcome is increased knowledge and skills to lobby and advocate for RMHR issues. Our first activity was build capacity of youth organization, on policy advocacy. Here we are looking at the ADH policy, then the GBV policy, National School Health Policy, National Sexuality Education Framework. And our person responsible, here we are looking at plan, then we are looking at reproductive health. We have SRH Alliance, we have SEHAD, then we have the consortium of Right Here, Right Now. And the timeline, we are looking at it to be done on a quarterly basis. The other activity that we are looking at is build capacity of youth organization on lobby and resource mobilization. We are looking at the person responsible to be planned, and then it can also be done on an annual basis. The next activity, we are looking at train media persons on effective reporting of ADH issues, and here we are looking at people having resources to be Reproductive Health Uganda and ACHEST. So we are suggesting that this should be a biannual activity. Then we are also suggesting that there should be an activity to do with follow-up on the trained media persons on effective reporting of ADH. This can also be done on, the training should be done on a quarterly basis, then the follow-up should be done on a biannual basis. Then the other activity is support forum members to participate in subnational, national, and regional ADH conferences and meetings. Here, the example we gave is National Stakeholders Dialogue on ADH. And we are saying that the people who could be having resources to support us here could be Reproductive Health and then Plan International. Then the last activity, we have conduct quarterly media cafes. We had not yet discussed about this. So as maybe group 3 is presenting, we'll be able to discuss and have a conclusive part of it. I thank you.
Unfortunately, you've clapped for yourselves. Fortunately, I'll request all the other groups to clap for you, then I'll also. All right. Just a point to mark. All those activities you're suggesting, were they there before or there were some additions? We have added in some wordings in the
Wordings.
That have been there, but
Okay.
also some new activities that have been added.
All right, please share so that we can pick the new activities. Over here, Madam Chair.
Our objective was strengthening national and local level coordination and accountability for ADH outcomes. We tricked it a bit based off the earlier discussion of the structure to read strengthening national, regional, and local level coordination and accountability for ADH outcomes. Our outcome 1 was realization of young people stroke ADH outcomes. We are still refining our outcomes. When we go to the activity, the first activity, which was initially there, was conduct quarterly ADH Forum meetings. We left that. The next activity was on the ADH technical working groups, which we refined a bit to say facilitate adolescent participation in ministry level ADH technical working groups. So that's the aspect that we added there. We also added an activity of strengthening the DICA's capacity to influence ADH issues at district level. The next activity we added, map out and work with influencers, especially youth parliaments at district level for ADH policy. We realized that at district level, these are some of the people that have the power and influence to be able to bring to light some of the ADH outcomes that we want to realize. The next was conduct the annual youth summit. That was left the way it was. Conduct the regional ADH dialogues. That was left. The next activity was looking at conducting national level policy dialogues with key stakeholders on key ADH policies. Now, the discussion we had here was on making this particular outcome very specific in terms of what policy are we pushing as a forum. We added here a couple of policies and documents and frameworks, but put a note that we can further discuss these different things and agree what are we influencing, what agenda, what policy are we pushing specifically, so that our advocacy is a bit smarter. So the ones we highlighted, the ending teenage pregnancy framework, we have the ADH policy, we have the school health policy, the child marriage should be guidelines, I think, the family planning guidelines, but really for us again as a forum to agree on what specific policy are we pushing. We highlighted an activity here of conduct annual culture health ministers forum. The team had a discussion on what outcome would have from that activity, and was suggesting alternatively to have it as work with influencer institutions like culture and religious leaders to address social cultural norms affecting ADH, or work with Ministry of Gender to orient the cultural institutions to understand ADH issues and their role. The rest of the activities, the other three around capacity, were left the way they are. We hadn't yet gotten to finalize the rest of the table.
The group is fortunate enough that we have clapped for you all together, but I request we clap again for all of us. All right. I think we have picked the points. We had Mr. Michael also presenting about DICAs. Something that I picked from your presentation is the DICA engagements that Michael and the Heroes program are doing. I don't know if Mr. Michael, you can also give us some space so that maybe we can plug in there, or member organizations within the forum can plug in to ensure that, you know, we follow closely how you're working with the DICAs in the given districts. We know Naguru is also supporting DICAs in a few districts. NYHN is building capacity of youth representatives on the DICAs, so it could be a holistic approach of working with the DICAs. Yes.
I have just had a small observation and a point of inquiry. As a gender activist, I don't know whether it was intentional that we had only female presenters from all the groups. If it was intentional, then I'm happy. Thank you.
I think it's in defense. Let me say, I and Joshua had taken over the floor for quite some time, so it's really good that the women have come up at this moment. Allow me to hand over to another very important woman now to wind up. Diana.
Diana, someone has something. Just 30 seconds.
I thank you, Arafat and Diana. Mine is in the morning. Olivia had hinted on, strengthening the representation of the adolescents on the technical teams. I don't know whether we also need to be intentional in ours to make sure that at least we track how far we have gone in including them at the national level in the technical discussions.
Very key question there. Ensuring that inclusion of young people as VHTs, technical working groups, DICAs.
Thank you very much. I'm just giving my own input to the discussion. Of course, I've heard the members submit, but I didn't hear much sustainability of the forum in this strategy that we are working on. So I think, to me, we need to look at us thinking about sustainability because it's as if we're depending on this CPI grant. how to sustain this, how do we engage members to ensure that they support this. But we must look at from the start sustainability of this agenda. Otherwise, a project will come and go, and then the forum crumbles. So we need to think as members how to sustain this forum outside the PI grant. Yeah, thank you.
Mine is simple. What is our inclusion criteria? How are we bringing on board people living with disability, most at-risk population, okay? People living with HIV/AIDS. How do we create the space for them to participate?
All right, I think the forum is inclusive enough. Given that the entire platform has inclusion of of persons with disability, HIV, and then the gender aspect, we ensure that the different forums also borrow that kind of platform. Raymond asked a very key question, sustainability. Maybe, Raymond, just to let you know that the forum as the forum is not receiving any funding from PAI. The funding is for the entire platform. So forums are only being supported. So it's also the role of the forums to mobilize resources for their implementation. I don't want to ask very hard questions for real, but I would want to ask organizations like Yadinet, Rahu, Plan. Of course, Naguru has given us some little money, and Plan International has supported us in this meeting. But what is the role of the other members? Those are very hard questions I don't want to ask. But we, I just didn't want to ask. All right, allow me hand over to Diana. Maybe she will answer some of those hard questions. I don't know. Anyway, over to you,
Thank
Diana.
you. I don't think those are hard questions, because the fact that we've been able to be here, it means we can be here another time. There are so many institutions here. I can see HIPS, I can see ADNET, I can see. So I think it is upon the forum leadership to also draw up a financial plan for the platform. I know that at institutional level, institutions have funds, you know, to support these coordination meetings, but they cannot support if you do not have a consolidated financial plan, you know, and a strategy for the platform. So as of when those are ready, they can be used as resource mobilization tools to facilitate the coordination of the what? Of the platform. So we again throw it back to the leadership. So if when we get the leadership in place, let them take up that role and responsibility of raising resources for the platform. So thank you so much, members, for participating into this group work and providing input, guidance, and sharing your opinions on how we should improve our advocacy priorities or agenda or roadmap. So would like you to share your input with Arafat on email so that they are able to amend the document. And I think these will be presented on Friday in the broader RMNCH+N platform meeting. Our friends online, we don't know if there is something that you want to mention or it's been put in the chat box. In case you have something to say before we get to the way forward, kindly let us know so that we give you the around 1 minute to say something. But we want to thank you for your contribution, and I will want to hand over back to Arafat and Joshua to lead us into the closure of this meeting. Yeah, so Arafat. Thank you.
Thank you. Hey, Anna, you're so mean with your hand claps, eh? Yeah, like that. So as Linda is preparing to give us our administrative remarks, I want to hijack someone. Dr. Gloria, please confirm if you're hearing me.
Arafat, I can hear you.
All right, Doctor, I kindly request in the next 1 or 2 minutes you give us some closing remarks. I know I've hijacked you, but I'm sure it's very okay.
Wow.
In
This is the definition of ever ready.
in 2 minutes, we are going to get back to you, Doctor. All right. So Linda is coming to give us some administrative remarks. Then Dr. Gloria will give us closing remarks. The reason why I've hijacked Dr. Gloria is in her closing remarks, I want her to tell us if World Vision will be willing to support our next meeting. I'm just thinking ahead. Anyone else who would want to support our next meeting? We know Naguru has really done us a favor for the past 2 meetings. Diana has already promised in the next meeting, we never know. We might have full support from Plan International, but also we want to be sure if our other partners will be able to get us some resources for the meetings. Hey, hey. I am.
I have one simple suggestion. It rhymes with Raymond's sustainability issue, but earlier on Joshua told us that we are all donors to the platform, right? And therefore my suggestion is, as a way forward, is it hard for the organizations herein to commit at least 1% of their annual budget to the forum? 1% I committed from UIP. Thank you.
So Uganda Young Positives has a budget of an annual budget of 200,000. 1% of that is how much? 2,000. $2,000. $2? $2,000. Okay. $2,000 was kubisam. That's about, yeah, it can support our one meeting. Thank you, UIP. We want to hear some more commitments from our members. We can call this the 1%. It's we want to liken it to the Uganda AIDS Commission 0.1%. Linda, we are waiting for you. And then you'll hand over the microphone virtually to Dr. Gloria.
Good afternoon, everyone. How are you? Thank you for making it today for today's meeting, the physical participants and the online participants. My work here is to simply give logistical highlights. We have some people that have only registered on the Naguru registration form, but we also have one from Plan. Ours has about 46 people. The one of Plan has 39. So they need to tally for accountability purposes. But thank you all. Kindly, if you've only registered on one form, please check with the lady at the registration, Vicky and Kevin. They will help you. So our facilitation will be coming through our funds as usual. It won't be late this time. Yes, it won't be late this time. We are so sorry about the delays that happened last time, but this time will be better, this week to be precise. Simply make sure you've given us your mobile money phone numbers and the names that tally for both the online participants and the physical participants. The registration forms are the same, so please take note. I hand over to Doctor. I officially hand over to Doctor to give us our closing remarks.
Thank you for the invitation and for officially allowing me to hand over. What many of us might not know is that
Nagut Center is very close to my heart because we worked with a team of young people. We were also young people then to set up the HIV services at Naguru Hospital. And our faculty and team were also a core part of that work. But also, adolescent health has always been close to my heart. I think that you even appreciate how important it is for us to reach out to adolescents when you're no longer an adolescent. Because many of us have, when we reflect back, there are probably things that we could have done or would not done, or done better, or influenced better if we had been even more empowered than we probably were. That being said, that I just want to appreciate each and everyone who has contributed to the success of the meeting, and to appreciate all of you adolescent health advocates. You know, adolescents are definitely, without a doubt, the future of this country. And we do recognize how important it is to reach them at a critical time when they need all of us. And also how important it is for us to listen to them so that we can respond to exactly what they need to be supported with. So I would like to thank Plan for facilitating the meeting, the organizers, the very engaging and interesting presentations about the good work that is being done by the different partners, and the presentation about, you know, the different things that we're planning to do in order to advance the adolescent health agenda. And I think I would like to recognize the Ministry of Health team. The adolescent health team is really vigilant and at the forefront of making sure that we push our adolescent health agenda forward. So thank you very much for the support. Each and every partner counts, each and every stakeholder is important if we are to realize progress and see better outcomes for our young people. In response to Arafat's question, Arafat, we are going to provide feedback on our support, but I would like to say that World Vision is committed to supporting adolescent health services. And at a later date, we'll probably have an opportunity to present some of the things that we've been able to do as World Vision in the area of adolescent health. So with those few remarks, I'm honored for being given this opportunity to close the meeting. And I would like to wish each and every one of us success and in everything that we do to advance the adolescent health agenda in the country. Thank you very, very much, and have a lovely afternoon and a nice day.
Bye.
All right. Thank you very much for joining us, everyone online who kept online from the time we started. I hope you have registered using the link that we shared. If you have not, please we request that you register again, because that's what we shall use to refund your data. To the members here, I don't think it's mu Buganda tekikirizibwa kwogera nga omuntu omukulu ayogedde. In English it is said like English is a very hard language. All right. Vicky has it is impossible. All right. Vicky has our coupons. For those ones who want to stay behind for your work, I'm not sure if you have the room for the afternoon, but bon appetit. Lunch bagisabidde. Group photo. Hey. So we can just convene in front here. Sorry, not behind. Nenga meeting here with.
Hunger is too much, I can't see properly. I don't know whether they're going to see me, the camera.
The man from Butareja, we need to account. We are not seeing you. Mister, we are not seeing you. Ongezeza hapa na yeye da. Mlindeko.
Nice one. Basekete dala.
Thank you so much.
Anything about the coupon? Somebody say something.
Kirungi zaina pasi.